അച്ചു അച്ചുമിയെ എടി സ്ക്രീൻ റെക്കോർഡ് ചെയ്യുന്ന എങ്ങനെയാ ഇതിനകത്ത്? സ്ക്രീൻ റെക്കോർഡ് ചെയ്യുന്ന എങ്ങനെയാ? സ്ക്രീൻ റെക്കോർഡ് ചെയ്യുന്ന എങ്ങനെയാ?
Good afternoon, everyone. I welcome you all to the scientific session O Conclave. I'd like to welcome all the judges and delegates to this session. Today's scientific session will be paper presentation by UGs. I welcome our judges of the session, Dr. Deepa, Professor and Head, Azizia Dental College, and Dr. Mithila, Senior Lecturer, Azizia Dental College. We are beginning our session. Judges kindly note our first presenter is UG paper 1. Judges kindly note our first presenter is UG paper number 1.
Am I audible, ma'am?
Yes, you're audible now, ma'am.
My screen, ma'am, is my screen visible?
Yes, it's visible.
Okay, I'll start, ma'am. I welcome you all to the world of genetics for few minutes. Good afternoon. Decoding the non-coding, a revelation in oral oncology. Oral cancer, which constitutes around 48% of head and neck cancer. 77,000 new cases and 52,000 deaths were reported annually in India. Generally, a 5-year survival rate is still below 50% in most of the countries. We come to the provisional diagnosis generally through the clinical examination and the conclusion through the biopsy. But the drawback for biopsy is it can result in damage to the neighboring tissues and is sometimes inappropriate to capture tumor heterogeneity. The conventional diagnostic methods are in an order from earlier to recent. First, visual examination with the histopathological examination, vital staining, transepithelial cytology, identity 3000, which follows the principle of autofluorescence, then fluorescence lifetime imaging, polymerase chain reaction, microbiome, artificial intelligence, and finally, proteomics, under which microRNA, which plays a vital role in the field of oncology. MicroRNAs, there are generally small non-coding RNAs containing 20 to 22 nucleotides, and it functions as either oncogenes or tumor suppressor genes. It plays an important role in regulation of gene expression. Its specialty is single microRNA targets multiple dysregulated genes. These microRNAs are generally found in the biological fluids like plasma, serum, saliva, cerebrospinal fluid, breast milk, urine, bronchial lavage, tears, seminal fluids, peritoneal fluids, ovarian follicular fluids. Its isolation is based on the phenol chloroform method. I've shown the diagrammatic representation here. And the analysis is done through the total RNA extraction first, then fractionation and ligation of the adapters, reverse transcription and PCR amplification, and then sequencing, and finally data is analyzed. It has a wide application in the systemic disorders for cancer, breast cancer, liver cancer, pancreatic cancer, colorectal cancer, and oral cancer, non-small cell lung cancer, cardiac hypertrophy, systemic lupus erythematosus, Down syndrome, rheumatoid arthritis, Alzheimer's, and psoriasis. Its application in the field of dentistry is first mentioned oral cancer, and then Sjogren syndrome, temporomandibular joint, osteoarthritis, periodontal and endodontal diseases, and oral lichen planus. These microRNAs can be used in the oral oncology as a biomarker. First, diagnostic biomarker, therapeutic biomarker, and prognostic biomarker. Since it has both diagnostic and therapeutic values, microRNAs are also called as theranostics. Here I've listed some of the microRNAs which are upregulated and downregulated in oral cancer, through which diagnosis could be done. The samples that I've mentioned here are serum, plasma, blood, oral cytology, and even saliva. What if salivary microRNAs are used as a diagnostic aid in oral cancer? Its advantages are low background of normal material and inhibiting substances, easy to handle, non-invasive, and can be repeatedly collected. And it has local contact with the lesions. Its disadvantages are lack of standardization procedures and variability in the levels of the salivary biomarkers. Its role as a therapeutic microRNA is it actually functions by two approaches: gain of function approach and loss of function approach. Gain of function approach works by stimulation of the tumor suppressor microRNAs, through which progression of cancer can be decreased. Loss of function approach works by the silencing of these oncogenic microRNAs, through which progression of cancer could be decreased. And microRNA is a prognostic marker. Dysregulated microRNA 31FP expression.
You have 1 more minute left.
Yes, ma'am. The cell invasion and metastasis has happened. Expression of 455-5P nodal status and stage, it indicates the stage of the oral cancer and even the nodal status. And a high expression of microRNA 99A indicates better prognosis, and 183 overexpression indicates poor prognosis. And the future trends and the challenges are, it are standard and the normalization methods, but it has a great future. It can be used as a nanoparticle-based delivery in the treatment of oral cancer. Unique microRNA antagonists could be developed to achieve personalized cancer therapy. And the future is actually microRNA map, which actually reprogramming cancer patients' microRNA genome. And these are the references. And thank you so much for your patience listening.
Thank you. Over to the judges.
Hello.
Yes, ma'am.
Can you name some microRNAs that are available or seen in the saliva?
Ma'am, microRNA 31 and microRNA 183 are those RNAs that are in the saliva samples, ma'am.
Okay. Do you think these microRNAs can be used beneficially for oral cancer screening?
Ma'am, no, ma'am. Like if it is if the oral cancer like squamous cell carcinomas, if it is well studied cancers, oral cancer like squamous cell carcinoma is the most common one, ma'am. So the most common could be studied, ma'am. And rare cases, we need some more investigations and clinical trials for that, ma'am. But common could be analyzed through this, ma'am.
Paper 1,
Over to you,
UG paper
Mila.
1. Yeah. UG paper 1.
Yes, ma'am.
Shall I ask you what is the feasibility of using mRNAs, microRNAs?
Ma'am, actually, the extraction methods and all the normalization methods are, we don't have standard protocols, ma'am. But if much more, it has to go, move on with the phase 2 trials, all, ma'am, then we can create a normal normalization methods, so that we'll get to know the microRNAs extraction and all this preservation on analysis of those, ma'am. We haven't crossed much clinical trials as of now, ma'am.
Okay,
And
fine.
its cost, it's not financially, it's costly too.
Okay. Yeah, we'll move on to the next one.
Thank you. Judges, please note the next presenter is paper number 2. Judges, please note the next presenter is UG paper number 2. Moving on, judges please note the next presenter is UG paper number 3. Judges kindly note the next presenter is UG paper number 3.
Good afternoon, all. Today I am here to present a paper on the topic photobiomodulation, a panacea for oral maladies. So, coming to the introduction, laser was first introduced by Myman on July 7. There are two kinds of lasers: high intensity or warm laser and low intensity or cold laser or low level laser or photobiomodulation. So, basically, what is photobiomodulation therapy or low level laser therapy? It is simply the application of red and near infrared light over the injuries to improve wound and soft tissue healing and to reduce inflammation and for pain relief. So this red and near infrared light comes under the wavelength of 600 nanometer to 1000 nanometer, and it can be produced by laser or high intensity LEDs or broadband light. So what is the mechanism of action? The light photons are absorbed by cells and it activates the mitochondria. Mitochondria contain chromophores, primarily cytochrome C oxidases, which contain heme and copper center. This will generate reactive oxygen species. At the same time, from the binding site of cytochrome C oxidases, nitric oxide is removed. This increases the ATP production. All together will lead to wound healing, reduction of inflammation, and relief of pain. So, what are the applications of photobiomodulation therapy in dentistry? There are so many applications like for management of recurrent after stomatitis and traumatic ulcers, for reduction of oral edema, for post-operative analgesia, recurrent intraoral and labral herpes, for management of lichen planus, to reduce pain of orthodontics, for management of temporomandibular disorders. So here we will discuss some of the applications of photobiomodulation therapy. First one is orofacial pain. We know that orofacial pain is a pain that is localized to the region above the neck, in front of the ear, below orbitomeatal line, and within the oral cavity. So, photobiomodulation therapy with a wavelength of 780 to 830 nanometer with gallium aluminum arsenate laser will be effective for the treatment of orofacial pain. Next, burning mouth syndrome. Photobiomodulation therapy for a period of 4 to 10 weeks by targeting sites like labial mucosa, tongue, and buccal mucosa by using diode lasers, gallium aluminum arsenate, and indium gallium aluminum phosphate with 830 nanometer and 685 nanometer respectively will be effective for treatment of burning mouth syndrome. Then oral mucositis. So oral mucositis is commonly seen in patients suffering from head and neck cancer as a side effect of chemo and radiotherapy. So here we use 630 to 970 nanometer wavelength of photobiomodulation therapy for treating cases of oral mucositis. Then temporomandibular disorders. It may be due to arthrogenic or myogenic causes. In case of arthrogenic cases, radiation is limited only to the temporomandibular joint area, while in myogenic cases, some masticatory muscles are also irradiated. So, according to Say et al., he recommended the treatment protocol based on 6 sessions of PBMT, 3 sessions per week for 2 weeks with gallium arsenate laser at 904 nanometer within 60 seconds will be shown significant improvement in the symptoms with the increased mouth opening ability. So, then comes the recurrent after stomatitis. It's a very common and painful ulcerative lesions of the oral cavity. So PBMT with a diode laser of 940 nanometer with a mode of 30 to 45 seconds with a pause of 10 to 20 seconds of total 2-minute sessions has shown faster reduction and pain healing of ulcers. Also, it shown prevents the recurrence even after 1 year follow-up. Then the oral lichen planus, we use 630 to 970 nanometer with a period of few seconds to 8 minutes and 2 to 3 sessions per week may be required for the complete healing of the lesion. Then herpes labialis, even though the primary conventional therapy includes symptomatic treatment and antivirals, PBMT has also been used effectively in the management of herpes labialis. Then comes the vesicular bullous lesions. According to Keffer et al., have successfully demonstrated PBMT in the management with the 980 nanometer wavelength with gallium aluminum arsenate diode laser used in non-contact mode. Then there are some contraindications like should wear safety spectacles and do not treat the site of any non-primary carcinoma or secondary metastasis, and do not treat directly over the developing fetus. And in epileptic patients, it might trigger a seizure episode.
You have 1 more minute left.
Okay. In conclusion, PBMT or photobiomodulation therapy is an evolving technology and it's very effective in treatment of several orofacial disorders by enabling enhanced wound healing, reducing inflammation and pain. And further newer applications of PBMT in dentistry for different disorders should be explored. So these are my references. Thank you.
Thank you. Over to the judges.
What are the disadvantages of photobiomodulation?
It has some precautions to use, like in eyes, when we use photobiomodulation therapy, except wearing the spectacles, it might damage to the eye. And in epileptic patients, it may trigger seizure episodes. And in primary or over the non-tumor cases, it may cause stimulation of the cells. And,
Intraorally, you are using it. If it is used intraorally, are there any contraindications or disadvantages? No. Okay, you said 780 to 830 nanometer is used for treating orofacial pain. Isn't it? Why that particular wavelength is selected?
It comes
For
as
orofacial pain.
it
Okay.
it will reduce the action potential and the conduction pathway so that the pain
This,
pathway
you are maintaining this particular wavelength, right? Okay, over to you, Mithila.
Yes, ma'am. So paper 3,
Yes,
I would
ma'am.
like to ask you what, like oral lichen plants, we are using photobiomodulation therapy, right?
Yes, ma'am.
So have you come across the percentage of population who have got complete remission from the treatment? Like the lesion does not come again, there is no recurrence of lesion. Is there any percentage of population in any study article?
Ma'am, there's a study which shows the 62% reduction.
62%. That means there can be recurrence. Is it? Okay. So what about the depth? Like when we are using the laser light or when we are using photobiomodulation therapy, is there any regarding the depth of penetration of this particular wavelength of light? Is there any like indication where you have to be taking care of the surrounding tissue or anything?
No,
Like
ma'am.
if you're targeting for lichen planus, if you're targeting the area buccal mucosa, should you be worried about the deeper structures? What about the depth of penetration?
It's relatively safe. It's an unlike high intensity laser, it has no heating effect. It's safe.
Fine. Fine, let's move on.
Thank you. Judges, please note the next presenter is UG paper number 4. Judges, kindly note the next presenter is UG paper number 4.
Good afternoon all. Today my presentation topic is knowledge and awareness about radiation protection among dental students. It's a questionnaire based study. First move on to the introduction. Dentists rely on X-ray radiation for the diagnosis, treatment and subsequent follow-up. Average dose arise from intraoral radiography is lower or comparable with the daily background radiation dose. However, every exposure to ionizing radiation entails the possibility of inducing a stochastic effect. Radiation hazards arising from these necessitate the need for ensuring proper radiation protection measures among the future dentists. So the background and rationale. In recent days, radiation has become a part of every technology and it reaches to radiation refers to the transmission of energy through space and matter. There are mainly two types of radiation, ionizing and non-ionizing radiation. X-ray come under the category of ionizing radiation, which is extensively used in medicine and dentistry. X-rays are used for diagnostic purpose in dental practice. The radiographer or dentist can expose the X-rays to process radiographs. This is done thoughtfully and responsibly with minimal radiation dose. In addition to the benefits, there are some risk factors also present for this radiation, generally known as the radiation hazards. To protect patients and operators from the harmful X-rays, we must be aware of the radiation protection measures and protocol. So the aim of the study was to assess the knowledge and awareness about radiation protection among the dental students. It is a cross-sectional survey-based study and it is conducted in a dental college of Kerala. The all dental students who consented to answer the questionnaire belonging to third year, final year students and interns are selected for the study. And it is conducted within 1 month and a one-to-one questionnaire format. And the data collected was statistically analyzed using SPSS software. The sample size was calculated using 4 PQ by D square. The survey tool was a pre-validated closed-ended questionnaire and it is distributed through Google Form and it contains 50 questions. So the result obtained from the study is presented here in the form of pie chart. So the 55.3% of the participants agreed with the statement that X-rays can reflect from the wall of the X-ray room. About 84.2% participants knew the radiation hazard symbol. When asked, do you think dental X-rays cause any harmful effect to the patient? About 76.3% responded yes, 9.2% responded no, and 13.2% were not aware of the exact answer. 69.7% were aware about the Alara principle. About 68.4% of the participants knew the deterministic and stochastic effects of radiation. 50% agreed with the statement high-speed film can reduce the radiation exposure. 73.7% of respondents considered that clinical examination and obtaining patient history is necessary before prescribing the radiograph. About 53.9% of the participants agreed with the statement that the dental radiographs are completely contraindicated in pregnant patients. About 53.9% of the participants provide lead apron and thyroid collar for patients before the exposure. About 68.4% were aware about the personal monitoring badge worn by the operator. And 81.6% believed that the operator must stand behind the lead barrier during exposure. And 72.4% agreed that the periodic checking of equipment efficiency is necessary. And 68.4% of the participants gave a positive response for the recommended distance for an operator position, and it is about 6 feet and 90 to 135 degrees. Only 53.9% participants knew that the intraoral film holding devices are used for stabilization of film. So the discussion, the knowledge and attitude among interns, final year and third year students has been found to be non-uniform. From the study, it was noticed that 96% of the interns, 60% of final year students, 5% of third year students were aware about Alara principle. However, in the study conducted by Arnold, EA and Jaffer, 40% of total students were aware of the Alara principle. In the present study, 92% of the interns, 65% of final years and 27% of third year students used lead apron regularly, whereas in similar study conducted by Rela R in 2019, almost 97% of the dental students were using lead apron. A lead apron is primary protective measure against radiation and it is made up of 0.25 to 1 mm thick lead. About 0.5 mm thick apron can attenuate approximately 90% or more of scattered radiation. About 20% of third year students, 56% of final year students, and 90% of interns were aware about personal monitoring badge worn by the operator during exposure. According to Shah, HG et al., 84% of the students were aware of the use of TLD badge, and in the study conducted by Prakash MP et al., 84% of the students were aware of use of TLD badges in their study. So from the study, it is clearly evident that a huge difference in the knowledge between dental interns, final year students and third year. So we concluded that the knowledge and awareness about radiation protection need to be emphasized well from the undergraduate level to ensure the elimination of radiation hazard. So this is the references. And thank you.
Over to the judges.
Hello.
Yes, ma'am.
What is AERB?
AERB.
Yeah.
Oh, sorry, ma'am.
Okay. So what are your suggestions based on your conclusions?
more awareness about radiation protection need to be emphasized well from the undergraduate level.
How?
Including more importance to radiation awareness protection and measures.
It's already included in the curriculum, no? Other than that, any other suggestions?
Clinical awareness also included.
Okay, over to you, Mithila.
Yes, ma'am. Paper 4.
Yes, ma'am.
This was done in one college, is it? I missed out that part. One college, huh?
Yes, ma'am, in our college.
Okay. So, can you name a few non-ionizing radiation?
Visible light, infrared rays.
No, methods, like how we take CT. Do we have any other methods using non-ionizing? What do you do for a pregnant lady? Excuse me?
Hello?
What do you do for a pregnant lady? What test? How do you which technique do you use? Do we use X-rays?
No, ma'am. At the time
Then,
of organogenesis, we know to prefer radiation.
yes, that I know, I understand. So what would you do, like during scanning? What is the procedure they are using for a pregnant lady?
Ultrasound.
Ah, yes, that's what I wanted. Okay. Any other non-ionizing techniques?
I don't know, ma'am.
Okay, fine. Next.
Thank you. Next presenter is UG paper number 5. Judges kindly note, next presenter is UG paper number 5.
A very good afternoon to one and all present here. My topic for today's presentation is the role of microRNA as biomarker in oral carcinogenesis. Oral cancer is among the most prevalent cancers worldwide, representing the 16th most common malignancy. Oral squamous cell carcinoma is the most common type of oral cancer. Oral cancer is one of the leading causes of death worldwide, with delayed clinical detection, poor prognosis, with specific biomarkers for the disease, and expensive therapeutic alternatives. The development of oral cancer is a multi-step process involving the accumulation of genetic as well as epigenetic alterations in key regulatory genes. So what is a microRNA? MicroRNA are a small regulatory non-coding RNA containing 20 to 22 nucleotides for which the altered expression can serve as potential biomarkers for the disease. The microRNA expression profiles and levels differ between patients with cancer and healthy individuals. The microRNAs are usually secreted into the body fluids in membrane-bound vesicles known as exosomes. The release of microRNA from exosomes is a significant mechanism of genetic exchange between cells. Circulating microRNAs are extremely stable, so it can be used as informative biomarkers. Coming to the function of microRNA, it regulates a post-transcriptional gene expression. That is, a microRNA, it inhibits protein synthesis by binding with mRNA in the cell cytoplasm and thus controlling gene expression. It also regulates cellular process and also regulates the oncogenes or oncosuppressor genes. MicroRNAs have short lengths, so they are known to regulate multiple signaling pathways by targeting more than one mRNA, thus playing a crucial role in oral carcinogenesis. Nevertheless, the identification of a specific microRNA may still shed light on oral cancer disease mechanism and pathophysiological changes and also help identify potential targets for therapy. Coming to the impact of microRNA dysregulation on carcinogenesis. In the first figure, you can see that the downregulation of tumor suppressor microRNA results in increased expression of oncogenes and further increased levels of tumor promoting proteins and thus increases carcinogenesis. In the second figure, you can see that the upregulation of oncogenic microRNA leads to repression of tumor suppressor gene expression and reduce expression of tumor suppressor proteins, thus increase in carcinogenesis. Talking about the role of microRNA as biomarker, it is easily accessible and has high specificity. It mediates activation or suppression of signaling pathways. It may function as oncogenes or tumor suppressor genes. Studies have also shown that circulating microRNA that is extremely stable are common in the body fluids of cancer patients. It is also through the exosome-mediated intercellular communication. The expression patterns of microRNA correlate with clinical stage, lymph node metastasis, and patient survival, thus indicating that microRNA can act as prognostic predictors. The microRNAs associated with oral cancer are the upregulated ones are microRNA 21, 24, 31, etc. And the downregulated ones are microRNA 100, 133, and 375. Talking about the methods of detection, it can be secreted from the saliva, serum, plasma, blood, and etc. And the main methods, techniques used are Northern blotting, PCR, sequencing, and microarray. Coming to the applications of microRNA, it can be used for early diagnosis, classification, prognosis, and therapeutic effects. Coming to the limitations of microRNA used as biomarker is that the detection methods like PCR, microarray are very complex procedures. So if simpler methods are used in the future, then detection of microRNA will be possible, such as an oral screening. Then it will be used in routine clinical investigation. Also, there can be lack of standardization in sample collection, processing, and analysis, which can lead to variation in the results. The future in therapeutics of microRNA, artificial restoration of expression or function of one or a limited number of microRNAs are called as microRNA replacement therapy. Coming to the conclusion, the future of microRNA-based biomarkers in oral carcinogenesis lies in developing targeted therapies, optimization of delivery and dosing, standardization of assay, and integration into clinical practice. These efforts have the potential to significantly improve the diagnosis, prognosis, and treatment of oral cancer, ultimately leading to better patient outcomes. MicroRNAs as therapeutic targets describes various approaches for delivering microRNA-based therapeutics, including nanoparticle-based delivery systems, viral vectors, and exosomes. Although microRNA have been proposed as potential diagnostic tool, their application in routine clinical investigation is yet to come. These are my references. Thank you.
Over to the judges.
Can you name some microRNAs that are used as tumor suppressors?
MicroRNA 133, A 375.
Okay. Can you all name some microRNA that are upregulated in leukoplakia? You have mentioned about that microRNAs that is downregulated and upregulated in oral cancer, right?
Yes, ma'am.
So what about leukoplakia? Name one.
MicroRNA 24.
Sure. Okay, what are the disadvantages of these microRNA studies compared to the other methods? Are you there?
Yes, ma'am. The collection is actually difficult and is expensive. So it cannot be used in routine clinical investigations.
So, okay. Over to you, Mithila.
Yes, ma'am. 5, right? Paper 5 alle.
Yes, ma'am.
You said microRNAs are there in the body fluids, right? So
Yes,
how far it has come, like usage of saliva as microRNAs from saliva? Can you?
Ma'am, I did not understand.
How can we use saliva as a biomarker in this particular aspect, microRNAs from saliva? Okay. Can you name few reasons for oral cancer? What are the main causative factors for oral cancer?
Ma'am, it can be both environmental factors and genetic factors. Talking about environmental factors, it can be smoking, spices, syphilis, sharp teeth, denture, improper denture.
Okay, okay, fine.
Thank you.
Thank you. Next presenter is UG paper number 6. Judges kindly note next presenter is UG paper number 6.
Hello, good afternoon, ma'am. Hello. Hello.
Hello.
Good afternoon, ma'am.
Good afternoon.
Ma'am, it's taking a little time for the screen to share, ma'am. Sorry for the delay.
It's okay.
Excuse me, ma'am.
Yes, please.
Ma'am,
Can you?
ma'am, sincere apologies, ma'am. It's not very difficult to open, ma'am.
Of this session, okay?
Okay, sir. I'll present at the end of the session, sir.
Okay.
Okay, sorry, ma'am. Sorry for the delay.
Judges, please note the next presenter is UG paper number 7. Judges, kindly note the next presenter is UG paper number 7. Paper 6, please stop sharing your screen.
A very warm good afternoon to one and all present here. Today, we are here on a paper presentation on the topic Assessment of Knowledge and Awareness Among Dental Students in Diagnosing Oral Precancerous Conditions and Lesions. Moving on to the introduction. Oral precancerous, oral pre-malignant conditions and lesions, it is a blanket term for a variety of pathologies that can arise from the oral cavity that has a potential to become a malignant lesion or a condition and can lead to oral cancer if they're not diagnosed at early stages and treated at early stages. Coming on to the epidemiologically, Kerala has the lowest incidence of oral cancer, while West Bengal has the highest incidence of oral cancer in the Indian population. Coming on to the etiology, the major etiology for most of the oral potentially malignant disorders are alcohol, tobacco, both in the form of smoke and smokeless forms, and beet liquid, and can cause all these pre-malignant disorders. So a study was conducted to explore the knowledge and awareness level among the dental students at Pushpagiri College of Dental Science in diagnosing oral precancerous lesions and condition. This helped us to assess the effectiveness of the current dental curriculum and if changes are to be made to improve the diagnostic ability and the knowledge of the budding dentists in the college. So a study was conducted in the form of a Google form, which was circulated among the interns, final years and third years, and 108 responses were recorded. Now, the following are the results and discussions of the study. Okay, the range of the age group was from 20 to 30 years, and out of the total responses, 76 were females, 32 were males, and 39.8% of the total responses recorded were those of the interns, followed by 32.4% of final years and 27.8% of third years. Now, coming on to the diagnostic ability response that was recorded, almost all of them got the opportunity to view the patient's oral mucosa routinely, and all of them got the opportunity to view the oral mucosa with oral lesions. And all of them felt it was a necessity to evaluate the risk factors during the examination. So coming on to the knowledge response, 88% of them felt that the red lesion was an early lesion of the oral cancer. 94% of them felt that white lesions, and 85.2% of them felt masses, and 62% of them felt ulcers as an early lesion of oral cancer. Now, everybody equivocally said that the patient with a suspicious white lesion must be referred to a specialist. 91% of them felt had an opportunity to view the oral precancerous lesion under a microscope. Now, 89% of them felt that the oral cancer and the campaigns were effective. 64% of them felt and they were confident enough in their knowledge level regarding the prevention and detection of the oral cancer. Now, everybody undoubtedly said that they like to update their information and knowledge, and also said that they would like to advise them about the risk factors of oral cancer. 72% of them were willing, 72% of them were willing to have an oral screening for themselves, and also will advise routine oral screening once they have graduated. Coming on to the conclusions, after conducting a study, we came to a conclusion that students do have a good knowledge about the etiology of oral cancer, and they're very alert in their examinations also. And the clinical aspect of the oral cancer and the carcinoma, however, were not so clear. And the difference regarding the knowledge and the attitude of the students during the oral cancer was minimal, and this varied with different undergraduate years when considered. And also, it was necessity from the study, it was necessary to implement clinical suspicion of oral cancer throughout the undergraduate courses so as to enable awareness and early diagnosis of oral cancer. These are our references. Thank you.
Thank you. Moving on to judges.
You said Kerala has the lowest incidence of oral cancer, isn't it?
Yes, ma'am.
What are the reasons?
Ma'am, basically, people are more aware of the oral hygienes, and they do go for regular checkups under a 6-month interval gap more than the other states in the country.
Okay. So that is the reason behind the lowest incidence of oral cancer.
And also they are really, they are aware and they are knowledge, they have been educated, and there are campaigns that are going on in the state.
So what is the duty of a dental professional?
So as a dental professional, it is necessity, it's a necessary to diagnose the lesions correctly.
How? So what about your information on identifying red and white lesions among your participants? Response from your participants?
Yes, ma'am.
The responses from the participants in identifying the red and white lesions. Your topic is pre-mal.
Yes, ma'am. Ma'am, in our assessment, 88% of them felt that the appearance of a red lesion was considered as an early lesion of oral cancer, and 94% of them felt white lesions as an early sign of oral cancer.
All red lesions are clinical or early represent early signs of malignancy. Yes or no?
Ma'am, it's not clear, ma'am.
So do you think all red lesions represent early signs of oral malignancy or oral cancers?
No, ma'am, it does not.
Okay. Okay. Mithila?
Yes, ma'am. Yes. Paper 7.
Yes, ma'am.
Yes. Okay. So in your, according to your study, there is a good knowledge awareness, right?
Yes, ma'am.
So how can we make it much better?
Ma'am, we can implement more seminars, more campaigns, and more webinars, more campaigns, more workshops, so that people become more qualified to detect oral cancer and they become updated.
Okay, so what do you think is the gold standard for diagnosis?
Biopsy, ma'am.
Physical examination is always the gold standard. So can you name few adjuncts used for screening adjuncts?
Ma'am, toluidine blue.
Yes.
Toluidine blue staining can be done.
Okay, fine. We'll move on to the.
Thank you. Judges, please note the next presenter is UG paper number 8. Judges, kindly note the next presenter is UG paper number 8.
Good afternoon, one and all in here. Ma'am, I'm audible.
Yes, you're audible.
Good afternoon, one and all present here. Today, I'm going to present a paper on comparison of diagnostic image quality of handheld and wall-mounted X-ray devices in intraoral periapical radiography. Just a second. IUPs are usually the main radiograph advice for imaging the structures of the teeth and periodontium for appropriate diagnosis and management. The production of radiographs require an image receptor and a patient and an X-ray source. The conventional X-ray source for intraoral radiograph is designed to fix to the wall or ceiling or mobile with the exposure button located behind a protective barrier to ensure that the operator receives no exposure to X-rays. However, the beam aiming device may unintentionally shift once the operator is obliged to depart, thus comprising the projection. These machines require a larger area and reinforced wall for cable fittings. Now, handheld or portable battery powered X-ray devices were developed in the early 1990s for military medicine and humanitarian missions due to its increased mobility and usefulness in attending non-ambulatory patients. This, coupled with economic benefits in terms of area and cable fittings, have increased its usage, especially in the private dental practices. The user-friendliness, direct visualization of the patient, and the better exposure controls are significant merits. Basic components of the handheld device include X-ray tube assembly, a radiation switch on the body, and a protective shield at the end of the cone to reduce backscatter radiation to the operator. The close proximity of the operator during exposure is advantageous in prevention or shifting of the beam indicating device or the patient, but is still a radiation safety concern. Another concern is the use of handheld X-ray device in the image quality. The exposure parameters or the instability of the machine in hand can lead to reduced sharpness, contrast, and motion artifacts. Few investigations have tried to compare both the devices in terms of image quality, radiation safety, and user friendliness. And there are few in vitro studies that appear to date in the literature seem to conflict on handheld image quality, but the increased popularity of this device among the dental professional warrant clear evidence about its comparability, if not superiority, with the wall-mounted X-ray devices. The aim and objective of my study is to compare contrast, sharpness, depiction of the relevant radiographic anatomy, and the motion blur. And the aim of the study is to compare the diagnostic image quality of IOP radiograph exposed by handheld and wall-mounted X-ray devices. Materials and method. The study is the in vitro study. Armamentarium uses the wall-mounted X-ray device machine, then the handheld X-ray device, then the size of the film is uses 31 into 41 mm E-speed double emulsion film, then XCP. Paralleling technique is used. Two macerated adult skull with teeth were used for exposure of the radiograph, and darkroom with appropriate processing solution was used for image processing of the radiographs. Then study design, in vitro experimental studies, then the study sample. We have selected two skulls, 14 sites were exposed per skull using paralleling technique, 7 sites for the maxilla and 7 sites for the mandible. So the total 14 sites which are included, and these are the teeth we have included in our study sample. And for each site, exposure first made by the wall mounted, followed by the handheld. Thus, for each skull of a total 28 radiographs were exposed. The same set of 28 radiographs were for 14 sites used for machines were exposed for the second skull. Thus, a total 56 radiographs were exposed and assessed. Then the procedure, the skull was placed on the chair and adjusted, aligning the occlusal plane parallel to the floor. The chair was adjusted as well. The film was placed in the RIN XCP holder as per the site. The parallelism of the film with the tooth was maintained, and the film was taped to the skull for the stabilization during the exposure. For the wall mounted, the beam indicated device for the wall mounted was aligned with the beam indicator ring of the paralleling device, and for the same for the handheld device. Then the exposure parameters on the machine was set, and the exposure button was pressed by the operator standing behind the lead barrier in case of the wall mounted, and in the case of handheld, the exposure parameters on the machine were set, then exposure button was pressed. Then in this, I have shown the positioning of the wall mounted X-ray device for the anterior.
You have 1 more minute left.
Then the procedure, the film was processed using the manual temperature method. And then in this picture, I have shown how I coded the radiographs. All the archive exposure were anonymized and were coded as pair for each side for analysis. And 3 radiologists with at least 5 years of experience were asked to individually assess the diagnostic image quality of the coded radiograph. And each radiologist observed was asked to declare their preference among 2 radiographs for each site on the basis of contrast, sharpness, depiction of relevant radiographic anatomy, and the presence of motion blur or artifacts. These are the parameters. And these are the results we get from our study. There's no preference, handheld preference, wall-mounted preference of the total. Then the biostatics descriptive stats was applied for the preference tallies, and to mitigate false response of the observer in the setting majority, chi-square test is used, and the p-value is 0.0186. The result is significant. And these are the studies I have mentioned which have occurred in the previous. Although the few and the relatively small studies that appear to date in the literature seem to conflict on handheld image quality, the study carried out illustrate the wall-mounted method of radiography for intraoral periapical radiography proved superior to the handheld modality. These are the conclusion. The results seem persistent even for individual rating preference. 61% observer preferred wall-mounted, 20% preferred handheld device, and 8% observer had no preference. These are the preferences. Thank you.
Thank you. Over to the judges.
What were the aims and objectives of your study?
Just give me.
Can you hear me? You don't know the aims and objectives?
Hello. Can you hear me?
Yes.
Hello.
Hello.
Can you hear me?
Yes, I can hear you. My question is, what are the aims and objectives of your study?
Ma'am, for my study, the objective of the study to be
aims, please.
Ma'am, to compare the diagnostic image quality of the IUP radiographs exposed by the handheld and the wall-mounted machines.
And the conclusion, the results?
Ma'am, the wall-mounted.
We're just skipping the slides, and that's why I'm asking these questions.
Sorry.
Okay, the final conclusion, you were skipping most of the slides were skipped, no? So,
yes,
you tell me
due to the time
results
limit.
of your study. Yeah.
Ma'am, the conclusion is the wall-mounted radiograph was preferred, followed by the handheld modality.
What is the reason for that?
Ma'am, because due to the motion blur present in the while using the handheld.
Okay. Are your study enhanced with or agree with the other similar studies?
Sorry, ma'am, can you repeat?
So there will be similar studies conducted, no?
Yes, ma'am.
Yeah.
Yes, ma'am.
So what about the results from their study and your study?
Ma'am, there is a conflict. They have just said that the wall mounted and handheld, they have not characterized on the motion blur and these things.
Okay. Okay, then over to you, Midila.
Yes, ma'am. Paper 8, right?
Yes, ma'am.
Okay. So the parameters, what were the parameters which you have used? Parameters as in what are the like KVP, MA, all those?
Ma'am, for the both the handheld and the wall mounted, we have used different parameters like tube voltage. We have used for wall mounted 70 kilovolt, and for the handheld we use 60 kilovolt. And the same with the exposure time, we have used 0.35 second for both the modalities, and tube current, total aluminum filtration, and the target angle focal sport size. We have used different.
So for both, you have kept different parameters, is it?
No, ma'am. For the tube voltage, I have different, but for the exposure time was same. That is 0.35 seconds.
Okay. So according to the result, wall mounted is better, right? That's what
Yes,
you have concluded.
Yes, ma'am.
Have you taken X-rays?
Yes, ma'am.
Like on a live patient, have you taken X-ray? You have quota,
no,
right?
ma'am. No, ma'am. We have in the study we have taken.
No. I'm not talking about the study. Otherwise,
yes, ma'am.
You have taken.
Yes,
right?
ma'am.
So what do you feel? Like after taking the X-ray?
Yes, ma'am.
Which one do you prefer? Have you used both this one?
Ma'am, on patient, I have used only the wall mounted, but on the skull, I have used both the modality.
Okay, fine. We'll move on to the next.
Okay, thank you, ma'am.
Thank you. Judges, please note the next presenter is UG paper number 9. Judges, kindly note the next presenter is UG paper number 9.
You are on mute.
Good afternoon, ma'am. Is it audible, ma'am?
Yes, it is audible. Can you share your presentation? It is audible. You can present. You're audible. You can take your presentation. Open your presentation. Oh, we can see your screen, but you have to open your PPT.
If you are not ready, next presenter, please.
We'll move on to the next presentation. We'll come back to you, paper number 9. Can you stop your screen share? Okay, thank you. Judges, kindly note the next presenter is UG paper number 10. Judges, please note the next presenter is UG paper number 10.
Good afternoon, ma'am. Am I audible, ma'am?
You're audible, but there is a disturbance.
Take care. Good afternoon, ma'am. I'm going to present about herpes zoster in an immunocompetent adolescent and uncommon occurrence. Herpes zoster is also known as shingles. It's an acute viral infection caused by reactivation of varicella zoster virus. It commonly occurs in immunocompromised patients. The triggering factors include exposure to virus and any illness, any immunosuppressive medications, or malignancy or emotional stress. It mainly occurs in adults and elderly patients, but it is very rare in children. In our case, there is a presence of odontologia, which is an early prodromal symptom because of the oral and maxillofacial distribution of the lesions. The pain, odontologia is caused due to the inflammation of the affected nerves due to the virus. The sites commonly affected are thoracic dermatomes, followed by cranial nerves, lumbar, cervical, and sacral nerves. In the trigeminal nerve, the ophthalmic branch is most commonly affected when compared to the maxillary and mandibular division branches. Now coming to the case, my patient is a 14-year-old male patient who has pain in the left upper back teeth region for past 1 week. Patient is apparently healthy with no history of previous varicella zoster infection. Patient has the history of pain, malaise, tingling sensation in the nose and palatal region. When seen extraorally, there is a presence of crops of vesicles on the left infraorbital region, which extends up to left tail of the nose, left upper lip, and skin near the left commissure. When seen intraorally, there are intact vesicles with erythematous base in the posterior palatal region, medial to left maxillary tuberosity, anterior palate inflamed maxillary, anterior gingiva, which do not cross the midline. And there are multiple vesicles seen in the left retromolar region and left buccal mucosa, which are less than 5 millimeter in size. Based on this information, we can say that unilateral presence of the unilateral presence of the lesion, we can say it is a herpes zoster infection involving the maxillary division of left trigeminal nerve. We gave the treatment of antiviral therapy. For antiviral, we gave acyclovir, and for soothing the lesions, we gave lotion calamine, and for reducing the pain, we gave paracetamol. The patient is recalled after 1 week for review. During the second visit, after 1 week, we can see that there is a formation of crest on the left side of the face, which indicates healing. But the intraoral lesions are just exaggerated, which are accompanied by itching and pain. This is because of the low dosage of the drugs. So we gave high dosage drugs such as valacyclovir and acivir ointment, accompanied by gabapentin, which reduces the nerve pain. And then we recalled the patient after 1 week for the third visit. Now the lesions and erosions are completely subsided, both extraorally and intraorally. We followed the patient for next 6 months, and the patient is completely normal, and there is no further infection. In this case, there is no previous infection with varicella zoster. So there may be we have subclinical infection without patient's knowledge, or it may be occurred through mild strain vaccination. Because of the unilateral distribution of the lesion involving the trigeminal nerve, we can say it is herpes zoster infection. Patient did not notice any odontogenic pain in that quadrant. This is due to the this is clue to the diagnosis of the disease. On the first visit, we gave low dosage drugs, so the patient was reported with exaggerated intraoral lesions. On the next visit, we increased the dosage and the lesions are completely subsided. So the patient is completely resolved now. In the conclusion, we can say that herpes zoster is but in this case denotes that it can also occur in young children and adolescent patients. Therefore, children should not be excluded in diagnosing herpes zoster infection. Thoracic herpes is common in children, but in this case, oral and maxillofacial lesions should have been considered in them. Dentist has a very important role in early diagnosis of herpes zoster infection due to its maxillofacial manifestation associated with prodromal symptoms such as odontologia. Early diagnosis with proper medication as per the body weight and age can completely cure the patient. And that's all, ma'am. Thank you, ma'am.
Thank you. Moving on to the judges.
Any lab tests done? Any lab investigations?
No, ma'am. Just no lab investigations, ma'am. Just clinical observance, ma'am.
Okay. Is there any lab investigation for confirming herpes zoster?
Yes, ma'am. Sang smear can confirm it, ma'am, for multinuclear giant cells.
So, in your case, what do you think the particular triggering factor?
Triggering factor may be due to the dormant exposure to virus, ma'am.
Dormant exposure to virus. That means a previous subclinical infection.
Yes, ma'am.
Okay. Tab gabapentin was given, no? What is the role of gabapentin? What is the role of gabapentin?
Mainly it is used for seizures, ma'am. But in this case, we can use to reduce the nerve pain, ma'am. Pain caused by the nerve inflammation, ma'am.
Dosage and duration?
For gabapentin,
dosage is 150 milligram.
Yes, ma'am.
Okay. So for how long? And your patient reported to you with odontalgia, right?
Yes, ma'am.
So what about the condition of odontalgia after the second and third review?
Odontalgia is also reduced, ma'am. With suppression of the vesicles, odontalgia is also reduced, ma'am.
Okay. Okay. Over to you, Nidhina.
Paper number 10, right?
Yes, ma'am.
So what is the most common complication of herpes zoster?
Herpes zoster, there is the dermatome is affected in the involved branch.
No, I'm asking about after the remission of the condition, after the remission of the disease, what can be the most complication which you can come through?
Neuralgia.
What neuralgia?
Trigeminal neuralgia.
No. What do you call the term? The term? It's there in the.
Sorry, ma'am. Post-herpetic neuralgia, ma'am.
Okay. So, in most conditions, viral infections, we do not give steroids, right?
Yes, ma'am.
But in this particular condition, we give steroid for what? It's linked to the previous question itself. The answer is linked to the previous question.
Ma'am, to suppress the inflammation, ma'am.
To suppress the reduce the post-herpetic neuralgia condition. Okay, so and what is the most unique feature? Like you have explained it in the intraoral findings also. So what is, once again I'm asking to confirm, what is the most peculiar feature in case of herpes zoster intraorally?
Presence of vesicles unilaterally, ma'am.
It stops right in the midline.
Yes, ma'am.
Right? Okay, fine.
Judges, please note our next presenter is UG paper number 11. Judges, please note our next presenter is UG paper number 11.
Yes, ma'am. Am I audible?
Yes, you're audible.
I guess my presentation, you can see my presentation, right? Hello?
No, we cannot see your presentation. Can you make it into full screen, your presentation?
Can I? Hello?
Yes.
Is my presentation visible?
No, your presentation is not visible. Make your presentation full screen. It was visible before.
Is it visible now?
Yes, it is visible.
So this is a case report. Good morning, everyone. This is a case report, a rare occurrence in myasthenia gravis. We'll see about that. So here the patient was a 22-year-old female patient. She reported to our department with a history of pain and swelling in the left side of her face. And the pain was actually gradual in onset, dull in nature, and it did not get relieved by any conservative measure. And the swelling was also gradual in onset. With this, we had a rough picture that it might be something involved with a benign condition. Okay. So next, and she also gave a history of chronic sinusitis and heaviness. Next, moving on to history, she gave a past medical history of myasthenia gravis right from her birth, and she was under medication of neostigmine for past 20 years. And then going on to past dental history, she was at the age of 12, she was undergoing orthodontic treatment, myofunctional appliance, and the personal history, family history, and all was normal. And then going to general examination, in central nervous system, there were no focal deficits seen. Cardiovascular system was normal. In musculoskeletal, had myotosis and weakness of muscle was seen. Next, going to extraoral examination. First, facial symmetry. There was facial asymmetry in the left side of the face. On inspecting it, it was extending on the maxillary region. Actually, it was extending 2 centimeter behind the angle of the mouth up to the infraorbital region. It was extending there. On palpation, it was firm and tender. And we also inspected the TMJ and palpated it for any abnormalities. No abnormalities were detected in that. Next, going on to intraoral examination. Here we look for missing teeth. and 2.8, that is the upper maxillary, and we also looked, and there were no decayed tooth found. Normal, gingiva was healthy, and in buccal mucosa at the region of 2.8, there was an obliteration in the buccal vestibule, which was erythematous and tender. And we also evaluated floor of oral cavity, palate, tongue, and all. It was all normal. Next, so that we went into radiographic interpretation. So in this radiographic interpretation, I have given you two OPGs. That is, the left one is at the age of 12 when she was taking orthodontic treatment. This one is at the present. Here you can see the migration of the tooth. And so we asked a history of any infection or trauma. The history was negative. So to do further investigation, we had to go to CT. So in this OPG, it showed a small haziness along that region, and the tooth was found it was ectopic on the region of infraorbital region. So next, going to CT, here it showed clearly that it is there's a radiolucency along that maxillary antrum region, roof of the maxillary antrum region, and there's a breaching in the posterior lateral wall, and there is a thinning of bone present in the medial wall, and the ectopic teeth is present near the infraorbital region. So it gave the reason for the migration of the tooth, because it's since the cystic swelling, it has caused pressure has caused the migration of this tooth. And then here we had ptosis, right? So the reason for ptosis was actually confused. The thing is, first reason was we thought since the ectopic teeth is near the inferior rectus muscle, it may be due to that. And the second reason was since the patient was herself a myasthenia gravis patient, so there was a confusion whether it was due to that or this one. So at last, we gave a provisional diagnosis of dentigeresis because it was an impacted ectopic teeth. So we thought it is a dentigeresis associated with that. And differential diagnosis where benign odontogenic tumor like ameloblastoma was given, and odontogenic keratosis, since it was very extensive, it was given, and dentigeresis, as I mentioned before. Next, investigations were done related to myasthenia gravis. All these are just antibody tests, anti-muscle specific kinase and all. Tensilon test is administering ephedromium to them. And then we also checked for acetylcholine. Before going to excisional biopsy, we did all these procedures. And the excisional biopsy was done by Caldwell-Loop procedure. You could see here.
You have 30 seconds more.
It had a chronic infiltration was there, and at last palisade pattern was seen, which was a distinct feature of final diagnosis was ectopic teeth with odontogenic keratosis in myasthenia gravis. So this was the final diagnosis made. And I would like to conclude it by telling that whenever a patient comes with a sinusitis history and it doesn't get managed by any conservative measures, you have to always look forward for an odontogenic cause. And this is a very rare condition. Only 28 non-dentate cases of ectopic teeth have been reported, out of which this is the first case to be reported in the myasthenia gravis.
Thank you. Over to the judges.
Can you just tell me the management of this patient?
Yeah, management was done by cyst enucleation.
Cyst enucleation. Then?
Yes.
What about the ectopic tooth?
Cyst enucleation was done, and yeah, with the ectopic tooth, it was enucleated, ma'am.
Okay. So this patient had myasthenia gravis 20 years back, right?
Yeah, right from her birth, she was having it.
Okay. Then after that, again, what was the confirmatory test done? You have mentioned nearly 4 tests, no? Lab investigation, electromyography, and other tests. Any immunofluorescence studies were conducted? What type of disease is myasthenia gravis?
Myasthenia gravis is autoimmune disorder.
Hello? Hello?
We didn't go with immunofluorescence. Instead, we looked for antibodies.
Okay. Was
Hello?
asked,
Is it?
this
Hello?
Okay. Was this patient under steroid treatment?
No, ma'am.
Ma'am. Okay.
She
No,
was
no steroids.
not under steroid treatment.
Okay. So what is the role of steroids in such patients?
To control
It's a very rare case, and that's why I'm asking.
so that is the point of giving steroid. Yes, ma'am. The thing is, you have to control the immune
So
system in
mostly
case
these
of
patients will be
autoimmune
given
disorder. So
steroids.
we are giving steroid.
Okay, okay.
Yes.
Okay, then over to you, Midla.
Okay, ma'am.
Yes, ma'am. So, could you repeat the provisional diagnosis which you have given in this case report?
It's too big.
Yes.
Provisional diagnosis.
Yeah, provisional diagnosis which was given was I've given actually dentigerous cyst in this as a provisional diagnosis, ma'am.
Okay, and differential diagnosis you have given amyloblastoma, right?
Yeah,
benign
I have given.
odontogenic tumor. But have you mentioned KCOT somewhere? Anywhere have you mentioned KCOT, odontogenic keratocyst? No, right?
No. I have mentioned it in differential diagnosis. I have mentioned okay.
Okay. And when you're saying amyloblastoma, which type of which variant were you actually thinking in mind?
Unicystic amyloblastoma.
Okay, okay, fine, fine. And you said something regarding, can you please mention the theories of cyst formation?
Theories of cyst formation. Cyst, it is actually a odontogenic cyst, which means it is due to formation.
You said something regarding the pressure and all, right?
Yeah, yes, ma'am. Yes, yes. It is. I told it because due to my. I told it for the migration of tooth, ma'am.
That's why I asked about the theories.
Okay.
Okay, fine. Read it up. Okay.
Okay, ma'am.
Yeah, we'll move forward.
Thank you.
Next
Judges,
is number 12, right?
No, ma'am. Next is UG paper number 13.
Last one was 11, right?
Yeah,
Last
yeah.
one was 11.
12 absent?
12 is not there.
12 is not there. So next is 13, right?
Yes, ma'am.
Okay.
UG paper number 13.
So, good afternoon, ma'am. Shall I start the presentation?
Yes, you can start.
So, ma'am, my presentation is based on spindle cell carcinoma, which is a rare case that is exceptionally seen in the oral cavity. It is a rare variant of the squamous cell carcinoma, also known by the following names as mentioned. So, spindle cell carcinoma, in my patient, it is noted in a 40-year-old female patient who reported to the dental hospital in the left lateral border of the tongue for the past 6 months. She has also a known medical history of diabetic and hypertension, and she's under medication. So on inspection, we can see that it's an exophytic polypoid growth of size 1 centimeter that's seen in the left lateral border of the tongue. It's also a sessile growth, which is firm in consistency and has hyperkeratotic area seen in the anterior part of the ventral surface of the tongue. It is seen lateroventrally on the occlusal surface of 3.7 and 3.8. So my provisional diagnosis could be suspected to be a carcinoma in the tongue. So these are the basic investigations, ma'am. So X-ray chest and the CT head and neck doesn't reveal any abnormalities. So we are going on to the next investigation, that is excisional biopsy. So in excisional biopsy, the healing was satisfactory as the tumor was of size 1 centimeter. Next, on histopathological features, under low power, we can see that it shows a epithelial component and lymphocytic infiltration. And spindle cells infiltration also seen up to the muscle layer. In the high power microscope, we can see that the red arrow marks usually show that it is a fascicular pattern, and the yellow arrow mark shows that it is a hyperchromatic nucleus associated with the giant cells. On immunohistochemistry, it reveals the P40 marker, which is the P marker that is seen in the spindle cell carcinoma. And the spindle cells were strong also for leptin. On further management, we can see that the patient was referred to the higher center. Hemiglossectomy was also done, followed by the radiation therapy, but the patient was lost to follow-up. Under SEER study, we can see that a meta-analysis of about 2,000 cases was done, and these are the following results. It most commonly occurs in the age group of 29 to 93 years, and most commonly the site is on the aerodigestive tract, that is extraorally, but intraorally, according to the Ellis-Corio study, we can see that it is on the lips, tongue, and the gingiva. The other predisposing factors are smoking, alcohol consumption, and also previous irradiation. But our patient didn't have any predisposing factor as she's a female patient. Now, the spindle cell carcinoma is a rare variant of squamous cell carcinoma, as mentioned earlier, and these are the theories of the spindle cell carcinoma. The spindle cell carcinoma has a worse prognosis than the squamous cell carcinoma, and it is also a poorly differentiated tumor, similar to that of the squamous cell carcinoma. And as it is an intrinsic tumor, and the treatment guidelines are also to be poorly detected, the treatment options can vary. They can go on for surgery or radiation therapy, but the surgery has a high management rate, as there is no high rate of recurrence in that treatment. They can also go for radiation therapy, but as there is a presence of dedifferentiation phenomenon, we are not going to opt for that. And it also has a poor prognosis, spindle cell carcinoma. Regular follow-up is very essential, and it can occur also without any predisposing factor, as in our case. And these are my references. Thank you.
Thank you. Over to the judges.
Why the name spindle cell carcinoma?
As the cells in the histological features, we can see that they are spindle-shaped, the epithelial component.
Okay, name some spindle cell neoplasms in the oral cavity.
Sorry, ma'am, I didn't get it.
Spindle cell neoplasms other than spindle cell carcinoma. What are the other types of spindle cell neoplasms that can occur in the oral cavity?
Fibrosarcoma.
Good. Then
squamous cell carcinoma.
Okay, in your case, why chest investigations was done before biopsy?
Sorry, ma'am.
In your case, chest investigation, no? Chest radiographs, it was done before biopsy or after biopsy?
Ma'am, it was done before biopsy, ma'am.
Why?
Ma'am, to just see the depth of the invasion.
Sorry?
To see the depth of invasion, ma'am. How long it has extended the tumor.
Okay, from the tongue.
Yes, ma'am.
Is there any other triggering factors there, like sharp tooth or broken restorations?
No, ma'am. No triggering factor in my case.
Okay. So, is there any other method for confirming the depth of inversion from that particular area from the primary site?
Ma'am, we can do molecular diagnosis like immunohistochemistry, molecular genetics.
So, do you think chest investigation before biopsy was right or wrong?
Chest investigation before biopsy. Sorry, ma'am.
Chest investigation, no routine chest radiographs were considered before the biopsy, and you told me that it is because of or to identify the depth of lesion, isn't it? Can you just summarize the recall or in the review and maintenance phase? Can you hear me?
6 months.
Yeah.
Yes, ma'am. I can hear you.
There. Follow-up was there.
No, ma'am. My patient didn't have any follow-up for 6 months.
Okay, over to you, Midila.
In this case, you have asked questions, ma'am. Deepa ma'am, we'll move on to the next one because you have already asked.
Yeah. 13. Next is 14.
Yes, judges, please note. Next presenter is UG paper number 14. Judges, please note. The next presenter is UG paper number 14.
We have 2 presentations pending, right?
Yes, ma'am. Number 6
9
and number 9.
Yeah, 9 and 6.
Yes, ma'am.
2 is also pending, I think.
No, ma'am. There is no number 2.
Present and number 9, ma'am. Can I present it now, ma'am?
Wait.
No.
Presenter 14.
UG paper 14, you can present it now.
Ma'am, I'm paper number 6. Can I
Hello?
present it, ma'am?
Six, please.
Hello, ma'am. Can you hear me?
Yes, ma'am.
Hello, madam. Can you hear me?
Yes. Yes, you are audible.
Okay. Okay, ma'am. Hello, ma'am. Can you hear me?
Yes, you're audible. You can present your. Please share your screen. Your screen is not visible.
Okay. Hello?
Yes, you're audible. You can.
You can see the screen, right, ma'am? You can see.
I can see the screen, but your presentation is not visible.
Okay. Can I start the presentation?
Your presentation is not. Yes, now it is visible. You can start the presentation.
Okay. Good afternoon, everybody, respected judges and all my dear participants. My topic about today's presentation is assessing oral cancer awareness among dental interns of the dental colleges in South Kerala. It is a descriptive cross-sectional study. And coming to the introduction, the origin of the term cancer is coined by Hippocrates, the father of medicine. He used the terms carcinoma and carcinoma to describe non-ulcer forming and ulcer forming tumors. Later, Celsus, Roman physician, translated the Greek term into cancer, Latin word for crab. Oral cancer ranks in the top 3 of all cancers in India, which accounts for over 30% of all cancers. 43% of cancer deaths are due to tobacco use, unhealthy diets, alcohol consumption, inactive lifestyles, and infection. In addition to lung cancer, tobacco consumption causes cancer to oral cavity, pharynx, larynx, and other parts of the body. The clinicians can increase survival rates if a cancerous lesion is detected at an early age. Dentists can perform oral examination, diagnose, and can prevent the disease. So in order to that, we need the awareness about the oral cancer. So this study is being conducted to assess the oral cancer awareness among dental interns in dental colleges in South Kerala. This is the materials and method. It is a descriptive cross-sectional study and a structured self-administered online-based questionnaire consisting of 10 questions was distributed to all interns through various social media platforms. And through stratified sampling technique and this formula, the study population is 77 and number of responses selected by sampling from each colleges has been given in this table. And this is my performer and this is the
Your
result.
slide is not changing. It is still at the introduction page.
Okay. And this is the results of the study. This is the number of responses selected by sampling from each colleges. And this is the performer of my study. And this is the responses of the questions in percentage. And the first question was, do you consider use of tobacco and betel chewing as a risk factor? 1.3% is still not aware about it. And nicotine content is more in BD, whereas 46.8% has opted cigarette. And regarding the combined effect of tobacco and alcohol, 1.3% is still not aware that the synergic effect is more cancerous than the consumption of tobacco only. And 7.8% is not aware about viral infection by HPV, and 7.8% does not think that ulcers that do not heal after 2 weeks can become malignant. Only 74% said that all red and white lesions are precancerous, whereas all red and white lesions are not precancerous. Here also there is a lack of awareness we can see. And now only 7.8% does not think that diet-rich in antioxidants can prevent oral cancer. Here there is lack of awareness in the prevention of oral cancer. And 37.7% is still not confident to diagnose and treat precancerous lesions and conditions. And 14% are not confident about the various tobacco cessation activities. And only 70% is confident to explain about the self-screen examination methods. And here comes the discussion. In some patients, oral cancer is preceded by pre-malignant oral lesions along with histopathological evidences. So in the present study, the interns' attitude and awareness towards the risk factors, diagnosis, screening, and prevention of oral cancer has been analyzed. And according to my study, 98.7% felt that tobacco as the principal factor for oral cancer, followed by betel chewing. Whereas in the study conducted by Pratibha et al., only 75.5% considered tobacco and betel chewing as the principal factor. And in our study, 74% of interns said that all red and white lesions can be precancerous. But in Pratibha's study, 26.18% only thinks that red and white lesions is considered as a precancerous lesion. This also shows the lack of awareness. And in Pratibha et al. Study, 39.37% identify non-healing ulcer as a manifestation of oral cancer. Whereas in our study, 92.2 interns is aware that non-healing ulcers after 2 weeks can become malignant. So from our study, it's very clear that all the interns know the various screening methods, diagnostic procedures, and the tobacco cessation counseling, but they are still not confident to explain it to the patient. Here comes the result. The 37% is still not confident to diagnose. The 22% is not confident to explain the screening methods, and 14% is not aware about the various tobacco cessation counseling. And we can conclude that the overall awareness of the dental interns about oral cancer is satisfactory when compared to the study conducted by Pratibha et al. Whereas in our study, we highlighted about the various areas where there is lack of awareness. So here, especially many are not aware about the nicotine content is more in BD than cigarette, and 7.8% still think that HPV cannot cause cancer. And ulcers that do not heal after 2 weeks can become malignant. 74% is not aware that all red and white lesions are not cancerous. And 22% cannot explain the cell screening methods to the patient, and 37.7 and 14% is not know about the diagnosis and the strategies of oral cancer. So from this study, we came to know that the awareness about oral cancer is still lacking. So more awareness about the diagnosis, screening, prevention, and treatment of oral cancer should be provided by conferences, study programs, seminars, and symposiums. Thus helps in early diagnosis and detection of oral cancer. Thank you.
Thank you. Over to the judges.
So based on your study, what are the strategies that can be implemented to create more awareness on oral cancer screening and oral cancer detection among dental students?
Ma'am, more oral cancer screening methods and knowledge to the students, interns, or the preclinical and clinical students should be given via CD programs or symposium or seminars. Even seminars can help them to know about various screening methods, the prevention strategies, counseling programs for the patients coming to the clinics. Through this, we can give them knowledge about, and they become aware about the various strategies of oral cancers and can prevent and diagnose various lesions in its early stage.
So what do you think about the nicotine content in BD and cigarette? Can you compare?
Nicotine content in BD is more than cigarette, because BD consists of 21.2 milligram per gram, whereas in cigarette, filtered cigarettes consist of 16.3 and unfiltered consist of 13.5 grams only. But in our study, only 53.2 interns know that BD is more. BD contains more nicotine than cigarette.
Okay. Over to you, Midla.
Yes, madam. So about the red and white lesions, how do you think we can propagate more awareness among the, I'm not talking about the interns, like third years, final years, all those students. How can we propagate more awareness regarding the red and white lesions?
Ma'am, from this study, it is seen that all, the question was all red and white lesions can become malignant, and 74% have answered that all red and white lesions are precancerous, whereas all red and white lesions are not precancerous. There are geographic tongue, median rhomboid glossitis, Fordyce granules, they are not cancerous. That means there is a large population.
So they need to know more clinical awareness regarding the subject also.
Yes, they need to know more about the subject. They have to study properly which all red and white lesions can become malignant, and what are the dysplastic features we can see in them. Then only they can diagnose it properly.
Okay, fine. We'll move on to the next one.
Thank you, ma'am.
Next is number 6, right? Or
yes, ma'am. Number 6.
Number 6.
Next presenter is UG paper number 6.
Okay.
Ma'am, can I start, ma'am?
Number 14, please stop sharing your screen. UG paper number 6.
Am I audible? Excuse me, ma'am.
Hello. Excuse me, ma'am.
Number 6, no? Participant number 6, no?
Yes, ma'am.
Yeah.
Shall I start, ma'am?
Yes, you can start.
Good afternoon, everyone. Good afternoon, everyone. What I have done is a pilot study to determine the association of candida with geographic tongue. As we all know, geographic tongue occurs as areas of depopulation of filiform papillae. The tongue, it is surrounded by raised white borders. The etiology of geographic tongue remains unknown, but the proposed etiology, as we have mentioned, is psychosomatic disorders, endocrine disorders, nutritional deficiency, and other dermatologic conditions like psoriasis and genetic factors. The study, it is mainly based on a relation to candida. The candida is a commensal organism in the oral mucosa and may turn opportunistic at times of decreased host immunity. The main aim of the study is to find out the association between the candidal carriage, the candidal infection, and occurrence of geographic tongue by comparing the prevalence of candida in patients with geographic tongue mucosa and clinically healthy tongue mucosa. It is a cross-sectional case control study we have done in oral medicine department. The study period was from 2021 to December 2021. We have employed convenient sampling method as it was easy. 30 patients were selected with a normal and 30 controls were selected in the same age group, socioeconomic status and sex, etc. Both the cases and controls will give them a pro forma with the questions about the medical conditions, oral hygiene practices, including the tongue cleaning, and responses were recorded. Certain cases were excluded, were not included. There were patients with a positive history of psoriasis, allergic diseases, atopy, asthma, eczema, contact allergy, and so on. Patients with tobacco habit and those wearing dentures. Patients with fissured tongue and any clinical features of depopulation other than geographic tongue, these were excluded from the study. Geographic tongue is described clinically as areas of erythema or pallor with atrophy of filiform papilla of tongue, surrounded by serpiginous white hyperkeratotic border with spontaneous resolution of the lesion in one area, and it may reappear in the dorsum of the tongue in another area, which may be symptomatic or asymptomatic. Symptoms like pain or burning sensation were noted and measured in the visual analog scale in our clinic. The lesion was described as active when the white border, when the raised white border was present, and passive when the white border is absent. Based on the number of depopulated areas, it was classified as mild, moderate, or severe. We took sterile cotton swab was taken, and a depopulated area was scrubbed 3 to 4 times and inoculated in Sabras dextrose agar. After 24 to 48 hours of incubation, the growth was assessed by the presence of cream color smooth surface colonies, which had a smell of ripe apples, which confirmed the presence of Candida albicans. The results were tabulated and analyzed. Descriptive data were checked for mean and standard deviation. The chi-square test was done for categorical variables and level of significance. From the study, we found out that the common age distribution in geographic tongue was 26 to 40. And the gender distribution was, it occurred more frequently in males than in females. Awareness of the condition, only 12 people were aware of the depopulation of the tongue, and most of them remained asymptomatic. One patient complained of pain and burning sensation, while 8 of the geographic tongue patients reported occasional burning sensation while consuming spicy food. The lesions were classified as mild, moderate, or hello. The lesions were classified as mild, moderate, or severe. 19 patients had active lesions, that is, they had raised white borders, while 11 patients had passive lesions without raised white borders. The moderate lesions were found most commonly in 18 patients, followed by mild in 7 patients, and severe cases were recorded in 5 patients. The fungal growth was seen in 2 culture plates, each in 2 groups, in 2 cases in cases and 2 cases in controls. But the microbiologist reported that it was due to contamination, not due to presence of Candida. Discussion. Geographic tongue, as we all know, is a self-limiting benign condition occurring on the tongue and rarely other parts of the oral mucosa. The etiology, as we have discussed earlier, is unknown. Candidal species exist in the oral cavity as commensal and may turn opportunistic if the host's immune response is altered. Normal candidal carriage in a healthy adult individual varies from 2 to 69%, according to Scully et al. Atrophic oral mucosa is also a local predisposing factor for formation of candidiasis. So hence taking all these things into consideration, this study was carried out to see whether candida is associated with the occurrence of geographic tongue in clinically healthy patients. And the occurrence of GT, that is geographic tongue, was similar. What we have done was similar to those study done in USA, but it was less than in Iran and Thailand and slightly more in Swedish. Gender differences were similar to USA study. And we have seen, it was more frequently seen in males than in females. Majority of the patients were unaware of the lesion, whereas those who were aware tried counter medications or topical. Okay. I'll conclude with the end slide. This was a pilot study done to see whether the occurrence of the geographic tongue and candidiasis was related. But in the end, we found out it was not related, ma'am. It may be due to various other etiologies. Thank you, ma'am.
Thank you. Over to the judges.
So can you name some systemic diseases associated with geographic tongue?
Systemic diseases like psoriasis.
Only psoriasis? And the patients with systemic diseases were included or not?
Ma'am, actually they were excluded, ma'am. Patients because
so
it may.
Yeah, that's fine. But which were the systemic conditions?
Ma'am, I can't get you.
Systemic conditions associated with geographic tongue. You should know, no? What are the systemic conditions? Then only you can exclude it.
Yes, ma'am.
It's a very simple question related to your topic. You presented very well, a very good topic. You need to know, no?
Yes, ma'am.
Systemic diseases associated with geographic tongue. Okay. What about the burning sensation? How many of your patients reported burning sensation?
Burning sensation was seen in around 8 patients, ma'am.
Okay, so in here also we should exclude, no, other systemic conditions where burning sensation can be produced.
Like it was like atrophic oral mucosa patients also will have a burning sensation. So
I'm asking you systemic diseases. Okay.
Systemic. Sorry.
Okay, fine. Dr. Midila?
Yes, ma'am. So paper number 6, what is the management for geographic tongue?
Since it is a self-limiting benign condition, no management is basically needed, but in severe cases, mouth rinses are used, ma'am, and topical anesthetics may be given if a burning sensation is severe, and vitamin supplements may be given, ma'am.
Okay. So at last, what did you find? Like, what was the conclusion? There is no relation, right?
Yeah, ma'am. There was no relation between geographic tongue and formation of candida, ma'am. That's what we have found.
Okay, fine. We'll move on to the next.
Thank you, ma'am.
Thank you. We appreciate the presence of Dr. Beena Madam and Dr. Arvind sir. Unfortunately, due to technical difficulties, there is a slight delay in the poster presentation. We shall commence with it soon. Judges, please note, next presenter is UG paper number 9.
Good afternoon, ma'am.
He died at the
Judges, please note, the next presenter is UG paper number 9.
Is my screen visible, ma'am?
No, your screen is not visible.
This is the last presentation, no?
Yes, this is the last presentation, ma'am.
Now is it visible, ma'am?
No, your presentation is not visible. You should click on the share screen, the green icon. Okay, now your screen is visible. Please take your presentation.
Good afternoon, ma'am. Today, my presentation is recent diagnostic advances in temporomandibular disorder. First, going to in advance, first let's brief into the temporomandibular disorder. Coming to an introduction, the term temporomandibular disorder is a collective term embracing a number of clinical problems that involve the masticatory muscles, temporomandibular joints, and associated structures. The disorders are characterized by facial pain, deviation in the mandibular movement, hyperalgesia, and clicking sound. Next, coming to one functional anatomy, the mandible exhibit hinge type movements and gliding movements. Coming to one classification, broadly TMD is classified into extra-articular and intra-articular. In extra-articular, there is muscle pain, myalgia, tendonitis, myositis, and spasm, muscle contracture, muscle hypertrophy, and neoplasm. Whereas in intra-articular, there is joint pain, arthralgia, and arthritis, or joint disorder, disc disorders, hypomobility, and hypermobility. And joint disease like degenerative joint disease, osteoarthritis, osteoarthrosis, and fractures. Next, etiology may be commonly that is stress, trauma, bruxism, infection, and developmental abnormality and neoplasms. Coming to one clinical features, in myalgia, there is a pain in the muscles of mastications upon palpations, whereas in arthralgia, there is pain in the TMJ upon palpation. In non-painful conditions, there is disc displacement with reduction and without reduction. There is clicking or crepitus sounds in the TMJ. The current diagnostic modalities are for heart tissue, there is plain film radiography, which include OPG, transcranial view, transpharyngeal view, and conventional tomography like CT and CBCT. For soft tissue, magnetic resonance imaging, ultrasonography, radio isotope study, and arthrography. Coming to an advances, which is biomarkers. Biomarker is characteristic that is objectively measured and evaluation of normal biological process, pathogenic process, and pharmacological response to therapeutic intervention. The biomolecular is a chemically stable molecule that can be easily quantifiable in the patients and could be used to predict onset, persistence, severity, and prognosis. The basis of biomarkers are genomics, transcriptomics, and proteomics. It is basically integrated omics for biomarker discovery. Coming to a diagnostic evaluation of painful temporomandibular disorder. Initially, it was observed that painful TMD are commonly caused by acute inflammation and trauma to the muscles or joint or adjacent structures. However, later it was noticed that TMD pain can occur due to other comorbid conditions. Therefore, to diagnosis painful TMD conditions, a special attention should be given to case history, clinical examination, imaging, laboratory investigations, and psychological assessment. The samples for biomarkers are for tissue biopsy, saliva, plasma, synovial fluid, and CSF. Coming to a relationship between TMD pain and biomarkers. For the study of painful TMD biomarkers, various steps have been identified, such as discovery of specific biomarkers. The biomarkers are molecular biomarkers, epigenetic and genetic biomarkers, neuroimaging biomarkers, sensory biomarkers, and biochemical biomarkers. The indications of biomarkers are to identify the risk factors, diagnostics, prognostic, predictive, and treatment response and monitoring. Coming to TMD biomarkers, first inflammatory cytokines. In that, interleukins, tumor necrosis factor, proteinase, and bradykinin. The common sources are synovial fluid, and the significances are it in progressions of TMD pain and involving the TMD pain, secondary to disc disorder and degenerative joint disease. And next group is neurotransmitters. It will glutamate, serotonin, and dopamine. The sources of the fluids are synovial fluid. Its significance is involved in pain processing, peripheral noise sensation, and central sensitizations of painful TMD. Next, neuropeptidase substance P and CGRP, calcitonin gene related peptidate. The sources is synovial fluid and saliva. It reflects joint pain progression and pathogenesis in patients with myofascial pain. Next, growth factors, NGF, nerve growth factor, and vascular endothelial growth factor. Sources are plasma and synovial fluid. Its significance is persistent pain and pain progression in TMJ disc disorder and degenerative joint disease. Next, neuroimaging markers. There are structural MRI, functional MRI, and structural and functional MRI.
You have 1 minute more.
Decreased trigeminal nerve fiber density, axonal diameter, myelations, and GMV correlated well with TMD pain in patients with TMJ synovitis and myofascial pain. Next, coming to QST, sensory functioning. In QST studies, observe abnormalities in somatosensory profile as well as enhanced pain sensitivity in patients with TMJ arthralgia and myofascial pain. Next, biomarkers are biochemical biomarkers, which is serum, serotonin receptor, as well as genetic and epigenetic factors, or along with the environmental factor, play a vital role in the development of chronic TMD pain. Next, coming to advantages and disadvantages. The advantages of biomarker: objective assessment, precision of measurement, reliable, and disease mechanism are often studied. Disadvantages: timing is critical, expensive, laboratory errors may occur, and normal range difficult to establish. Coming to future perspectives and conclusions. Analysis of biomolecular markers of temporomandibular disorder would aid in early diagnosis, which helps in optimizing treatment plan, which results in overall prognosis. And it is still needed to be explored whether these potential biomarkers can fulfill the considerations of reliability and practicality in terms of replications of studies on heterogeneous and large-scale sample size population. In future, more clinical and experimental biomarker research is needed on heterogeneous model and patients with TMD and other comorbid conditions. These are the some reference I referred. Thank you.
Thank you. Over to the judges.
Name some synovial tissue biomarkers for TMD diseases.
Cytokines like inflammatory cytokines, interleukins, serotonin, dopamine.
What is the role of CBCT in TMJ imaging? CBCT?
To diagnostic assessment of variety of TMJ conditions. The imaging are which helps for early treatment.
Okay, so since your topic is based on markers for TMJ diseases, can you mention or can you suggest some genetic markers? You have already mentioned it under your future perspectives, genetic biomarkers.
P53, TP53.
In serum or saliva? Okay, fine. Over to you, Midila. Yes, please. Hello.
Yes, ma'am.
Okay, over to you, Midila.
Okay, ma'am. Okay. Paper number 9, right?
Yes, ma'am.
Can you name few TMJ disorders?
Tendonitis, disc displacement with reduction, disc displacement without reduction.
Okay, so is there any disadvantage like during the collection of the sample? What is the most common sample which is collected?
Synovial fluid.
So is there any disadvantage associated with that? Okay, fine. Thank you.
Thank you.
Thank you, ma'am.
We have come to the end of our UG paper presentation. Thank you, Dr. Deepa ma'am and Dr. Mithila ma'am, for giving us your time and patience. As a token of our gratitude, we would like to present you the certificate of appreciation. Thank you, Mithila ma'am.
Thank you.
Thank you, Deepa ma'am.
You're welcome.
Once again, thank you all. The results will be announced.
I have a doubt, okay? Dr. Mithila here. What about the UG paper 2? Is there anyone? No, right?
There's only session 1. There's only UG paper session 1.
No, UG paper 2, number 2.
Participant 2.
No,
UG
there is no
paper
2, ma'am.
Samson, no?
Yeah, no, there is no number 2.
No, it is given in the paper.
No, ma'am, there is a confusion. There is no number 2.
Okay, fine.
Okay. Thank you. Once again, thank you all. The results will be announced later. We'll now start our UG poster presentation. We apologize for the delay. Good afternoon, everyone. I welcome you all to the scientific session O Conclave. I'd like to welcome all the judges and delegates to the session. Today's scientific session will be UG poster presentation. I welcome our judges of the session. Dr. Beena Verma, Madam, Professor Emeritus, Amrita School of Dentistry, and Dr. Aravind MS, Reader, Amrita School of Dentistry. Welcome, judges. We are beginning our session. Judges, kindly note our first presenter is UG poster number 1. Judges, please note our first presenter is UG poster number 1.
Okay, you can start. Good afternoon, ma'am. Can I start my presentation?
Yes, you can start. Please share your screen. All delegates, please note for the poster presentation, the time limit is 3 minutes and discussion 2 minutes. Paper number 1, you can start your presentation.
Hello. Hello.
Paper number 1, you're on mute. You're not audible. Please unmute yourself.
Ma'am, can you hear me now?
Yes, now you're audible.
Can I start from the first, ma'am?
Yes.
Is my slide visible, ma'am?
Yes, your slide is visible. You can start now.
Yes, ma'am. Good afternoon, fellow students and judges. Today I'll be talking about the advanced imaging for disease of the tongue. The tongue is the centerpiece of the oral cavity and the oropharynx. It enables taste of food and plays a critical role in the formation of food bolus and deglutition. The tongue is also crucial for speech, as we all know. Given the importance of the tongue, unlike the tissues of the oral cavity, it's a pool of occult diseases. The investigations of tongue begins with the clinical examination and extends the use of few specialized imaging modalities that we'll be talking about today. The magnetic resonance imaging is the first interest of imaging. The tongue being a soft tissue is not very well seen in other imaging techniques. So the magnetic resonance provides excellent soft tissue resolution and becomes the first imaging technique that we use for tongue abnormalities. It's proven to provide great details for soft tissue structures. It has the ability to provide multiple sections, which allows accurate delineation of the lingual musculature as well as the extent of the tumor infiltration. In selected sections, info on the tongue base involvement and the extent of the pharyngeal infiltration that can be seen in CT can be seen below. The selected section shows lingual thyroglossal duct cyst, which appears hyper-intense in T1 and T2 sections. And vascular malformation can also be seen. Oral squamous cell carcinoma is a familiar and most important noma in the tongue, which can be seen. This MRA plays an important role in the diagnosis of the oral squamous cell carcinoma and how the metastasis happens in this. The pictures here shows metastasis of oral cell carcinoma in the pharyngeal invasion and the submandibular lymph node involvement. The major disadvantage of magnetic resonance imaging would be that the whole process takes about 45 minutes and it's very disadvantageous for claustrophobic patients. But still, it stands first in the investigation techniques. Our next interest of imaging would be the contrast enhanced multi-slice computed tomography. And the normal CT cannot be used for tongue lesions as the resonance of normal CT is very low. To enhance this contrast resolution, we add a contrast media. The usually added contrast media is Iponian 300, 50 ml of this injected IV, and this can be seen through CT. Ionizing radiation, short acquisition time is used. Superior spectral resolution and used for assessment of cortical bone involvement and the metastatic lymph node. The photo given below is the projection of how the renal mesocyte tumor has gone metastasis into the tongue. The extent of this contrast enhanced multi-slice computed tomography is dual energy computed tomography. The picture shown below is that it uses two fan beamed external sources used. It enables visualization of virtual non-contrast images. Better identification of tumor margins can be seen. It differentiates metastatic nodules, differentiates inflammatory and normal nodules, and also used for differentiation between disease and post-treatment methods. The major advantage of this to the normal CT is that the attenuation is much more less in this dual energy computed tomography. Another extent of this contrast enhanced multi-slice computed tomography is the fusion imaging, which is seen in the left bottom of our poster. It detects micrometastasis of lymph nodes. The major function of this is that CT gives us anatomic images, but the PET gives us about functional images. But the major disadvantage of PET is that the resolution is very low. To overcome this, we have combined both PET and CT in this fusion imaging. The images shown here is the first the CT image, the second one is the PET image with low resolution. Combining these both, we can see the fusion imaging.
The time's over. Please conclude your presentation.
Thank you.
Conclude.
Thank you. Concluding my presentation, the various investigations I've given here is magnetic resonance imaging used widely because MSCT, the intraoral ultrasonography, which has both sector sections and simple sections, photoacoustic ultrasonography, single radiography, and also I mentioned the recent advancement, which includes mobile and enabled tongue diagnosis. Thank you.
What are your references?
I mostly used articles, ma'am.
No, references are not there. That's why I asked.
Okay. Do you want me to mention my articles, ma'am?
No, it's okay. So, which is the most common imaging modality that we use?
We use MRI imaging for tongue. Because
commonly used.
The advanced radiographic imaging, ma'am.
Imaging. Commonly used imaging. Very common. All these advanced imaging are not available everywhere, no?
Use X-rays normally, ma'am.
For tongue.
Ultrasonography can be used, ma'am.
Yeah. Okay.
Intraoral ultrasonography, ma'am.
Arvind?
Yeah, doctor. So, from an MRI, if you are suspecting an inflammatory pathology or if you are suspecting neuropathology, which set will be looked at?
Yes, sir. I cannot get you, sir. Can you? In MRI?
In MRI, if you are
yes, sir.
suspecting any pathology, which
any
session
pathologies
do you look at? Yeah, T1 or T2?
We use T2, sir.
T2. Neoplastic?
Neoplastic. T1, sir.
Can you tell me an example for a neoplastic inflammatory pathology of the tongue?
Yes, sir. Granular cell tumor of the tongue, sir, and then your tumor caused by human papillomavirus, squamous cell carcinoma.
Can you just tell me a radiography?
Yes, sir.
Can you just explain a little bit
about oral squamous cell carcinomas?
radiography?
Radiograph of oral squamous cell carcinoma, sir.
Doctors mentioned in your poster, right?
Yes, sir. Yes, sir. Do you want me to explain about the radiograph mentioned in my poster, sir?
Are you any doctor?
Sir?
Are you able to hear me?
So, not clearly, sir. I can hear you in bits and pieces.
Okay, one thing, your poster looks really good. Okay.
Thank you, sir.
One, the flow in talk about information, you can give your information in that order itself. Okay.
Okay,
So that
sir.
you don't go from contrast enhanced CT in center of the presentation to one corner of the, your poster for the next.
Okay, sir.
And I have to a little more detail of it. The time constraint.
Hello. Hello, sir.
Move
Can you
to the
hear
next.
me?
അരവിന്ദന്റെ ശബ്ദം മുറിഞ്ഞിട്ടാ വരുന്നത് കേട്ടോ, ക്ലിയർ ആവുന്നില്ല.
Thank you. Moving on. Judges, please note the next presenter is UG poster number 2. Judges, kindly note the next presenter is UG poster number 2.
Good afternoon, ma'am. Good afternoon, am I audible?
Yes.
Good afternoon, ma'am. Am I audible?
Yes, you're audible.
But your screen is not visible.
Please share your presentation.
It says I cannot share my presentation when somebody else is sharing.
UG poster number 1, please stop sharing your screen.
Ma'am, is my screen visible?
Yes, you're audible.
Is my screen visible?
Yes, it is visible.
All right. So, good afternoon, everybody. I'm going to present a poster on the topic tongue mapping. Tongue is an essential internal organ unaffected by the external environment as it is located well within the oral cavity. The dorsal surface of the tongue provides significant details from a morphological and structural point of view due to genetic independence, stability over time, and physical protection. It is extremely difficult to forge and exhibit a great amount of information along with visual differences in shape, texture, and patterns. These patterns are characteristics of every individual and differ even between identical twins, and they can be collectively called the tongue print. Now, tongue print is a new biometric authentication tool that is unique and cannot be easily forged because no two tongue prints are similar. And here we are going to present a poster based on a pilot study, the objective of which was to collect the information in order to better understand the role of tongue prints in forensic odontology. The method used is such that the subjects were chosen from different places depending on age groups, and the study was conducted on a total of 20 male and female adults, about 24 years, whose tongue were examined and photographed after taking consent for allowing creation of a database of tongue. Now, individuals suffering from HIV, contagious diseases, systemic diseases, or having a habit of smoking or consuming were excluded from the study. The results of the study showed that out of the 20 patients who were taken, 10 of them were males and 10 of them were females. And the fissures that were were the most common surface textural characteristic that was observed in the participants. Now, fissures were not observed in 30% of the males and 20% of the females. Central fissures were predominant in both males and females. It is observed that 70% of males and 80% of females. And the next characteristic that was taken into account was the depth of the fissure. They were categorized as either shallow or deep based on visual inspection. It was observed that fissures were shallow in 71.42% of females, and deep fissures were common in 75% of males. 25% of males has shallow fissures, and 28.5% of females has deep fissures. On analyzing the shape of the tongue, it was found that the most common shape was U-shape in both males and females, 50 and 70% respectively. followed by V shape, which was more common in males, 50%, than females, that was 30%. In conclusion, data obtained from the oral cavity can help in identifying individuals or providing information needed in a legal process. Now, only little investigation has been conducted on analyzing tongue as a biometrics. Thus, continuation of this work will instigate the fusion of all possible tongue features, including color, shape, and texture, in order to better human identification. Thank you.
Thank you. Over to judges.
Doctor, are you aware of any changes that would happen in the soft tissue after a patient dies, after the death of the patient? Do you know the changes that happen?
No, sir.
Okay. Do you think that would affect probably your assessment when you're going in for a postmortem assessment?
Yes, sir, most probably, because maybe the features of the fissures may change. The cells, the fissures may become blanch, they may blanch, so it may affect.
Okay. Would it create any kind of changes when you're trying to do it with an ante-mortem to a postmortem assessment?
Sir?
You are obviously will be comparing an ante-mortem to a postmortem assessment, right?
Yes, sir, and not just that. We were also thinking it's basically kind of like thumbprints and retinal scans. We can also use it to identify, in criminal cases or something, if there is a criminal, then we can maybe use it to identify the identity of the person. That way also, not just postmortem, maybe also.
As in gender identification?
Yeah. So gender identification also, because we found that some of the features were like more common in females and more common some others were more common in males. So this was a pilot study. So out of which we checked, there were some features that were more common in males, like the shape of the tongue and the presence of fissures. And there were some features that, for example, once we saw that deep fissures were a little bit more common in males. So there are some gender can also be. We believe that gender can also be distinguished. We need to study more, so just the pilot study.
Okay, doctor. Thank you.
How much time before how much time should you get this done if it is a post-mortem thing? And usually we don't keep that tongue imprints, to compare it with ante-mortem. So how far is it practically applicable? If at all you want to compare.
Ma'am?
If at all you want to compare ante-mortem and post-mortem, we don't usually keep the thumbprints, thumb tracing. So how far is it practically applicable? That's one thing. And if at all, how fast would you have to get it done? It's a modification of what Arvind asked.
Okay. Ma'am, we are not that. We haven't really conducted it that far. We have not gone that far into the study. So I don't exactly know how much it is going to affect any ante-mortem tongue mapping or tongue splitting. We don't know how much it is going to affect how different it is going to be ante-mortem and post-mortem, because we haven't gone that deep into the study. We just wanted to check the feasibility of how possible it was and how patients were going to open up to this idea. So I'm not so sure about that.
I know the second part. How fast should you get it done if it is done in postmortem?
Maybe I don't remember. Maybe
within
hours.
How much time?
2 hours. 24 hours. 24 hours.
What is rigor mortis?
Rigor mortis is when immediately, like after the patient is dead.
And how much time will it take for rigor mortis to set in?
2 hours.
That's all?
After 2 hours.
Okay.
Thank you.
As a suggestion, it would be better if you can add references in your presentation.
Yeah, okay. sir.
Moving on. Judges, please note the next presenter is UG poster number 3. Judges, please note the next presenter is UG poster number 3.
Hello, am I audible, ma'am? Hello,
Yes, you're audible. Please share your screen.
am I audible, ma'am?
Yes, you're audible.
Okay, ma'am. Thank you, ma'am. Good evening, one and all. Today, I'm here to present a poster on topic ergonomics in oral medicine. So talking about it, the successful application of ergonomics assures high productivity, avoidance of illnesses, injuries, and thereby increased satisfaction among workers. Unsuccessful application, on the other hand, can lead to work-related musculoskeletal disorders. So coming to topic, ergonomics, it's a study of work including the task, the technology, and the environment in relation to human capabilities, which leads to improved productivity, reduced injuries, and greater work satisfaction. Ergonomic risk factors include repetition motions, especially in our daily clinical practice. We do scaling, like that procedures causes repetitive motions, awkward postures followed by clinicians like forward bending of their neck during procedures, vibration, especially by hand instruments as well as air odor, then force that we exert during the excessive force that we exert during the time of extraction, then contact stress while we grip small instruments for prolonged period of time. Next, the poster tells us about the musculoskeletal disorders. They are relevant in case of ergonomics in oral medicine. They're work-related musculoskeletal illnesses, and they're having a progressive development, chronic progressive development, and they can affect the ligaments, spine, cartilage, nerves, tendons, and they are otherwise called as the cumulative trauma disorders. And the consequences of this musculoskeletal disorders among the clinicians include decreased range of motion, loss of normal sensation, reduced grip strength, loss of coordination, and hypermobility in the hands and fingers. So now the poster tells us about how the posture followed by the clinician and the temporomandibular joint pain are correlated. So forward head postures during the clinical procedures can cause passive tension on infrahyoid and suprahyoid. Thus, resting posture of the mandible is altered, and the mandible will be pulled inferiorly and posteriorly, altering the condylar position, and this may lead to TMJ pain. So here, the ergonomic posture is highly relevant. The ergonomic posture tells us about that while doing procedures, the shoulders must be relaxed and the straight must be back, and also our feet as well as thigh must be flat on the floor, and healthy hip as well as knee joints must be there, and this will result in proper circulation and thereby proper ergonomics is followed. And thus we can conclude that dental professionals are prone to unique muscular imbalances, and ergonomic interventions are required to maintain optimal health during the course of their career. Thank you.
Can you suggest some syndromes associated with work-related disorders? Can you
It's not
suggest
audible,
some
ma'am.
syndrome? Can you hear me? Are you
Yes,
able
ma'am.
to
Yes,
hear
ma'am.
me?
Yes, ma'am. Yes, ma'am.
Some syndromes associated with work-related disorders. Mostly because of repeated motions and awkward postures.
Ma'am, spondylosis?
No. Syndromes. Okay. Is there any single posture which is ideal?
Ma'am, posture with our shoulder as well as the head push straight, back straight.
No, actually, the thing is there is no single ideal position, because if you continue in that position, again, the muscles are going to be compressed. So you have to find one or two positions and shift between these. Otherwise,
Yes, ma'am.
again, it is going to be the same. Okay.
Yes, ma'am.
Where are your references?
Ma'am?
References.
Sorry, ma'am.
References. Can you hear me?
Yes, ma'am. Yes, ma'am. I can hear you. Yes, ma'am.
Reference. You
Yes,
haven't
ma'am.
put any
It's
note.
from different articles, ma'am.
No. Here you have to put no. We should know from where you got it.
Oh, yes, ma'am. Sorry, ma'am.
It's okay. Arvind?
Yeah, doctor. So I would like to know what is that you're trying to highlight in ergonomic posture in oral medicine.
So there's no definite posture that must be followed, but it must ensure improves productivity and greater work satisfaction among the clinicians.
What is that you're specifically highlighting in oral medicine?
Different TMJ problems will be produced if a posture is not correct.
I think that's a general statement for all dentists, right? Or work-related issues, right?
Yes, sir.
Okay, are you aware of imagine because of not following ergonomics and you end up getting muscle issues or carpal tunnel syndrome or anything like that? So how can you manage this? I think there is a huge void in that area because we never focus on the management of if at all what has to be done. Not only based on posture, there are techniques that you can actually apply in between procedures. There are physiotherapeutic techniques that you can do that would reduce the stress on ligaments, joints, tendons, so that in between procedures also these 2-minute, 1-minute exercises will help you out. Okay. I'm very happy that you highlighted this because I remember during my post-graduation day, we had an exclusive session on ergonomics, and there were a couple of people coming in, and one of the person was a physiotherapist. Okay, and they had a joint team with an orthopedic people as well, and they had suggestions on during procedures what are the small breaks that you can take apart from your ergonomic posture alone, okay, which would actually help all the dentists to come down with all these problems related to dentistry. So,
yes, sir. Yes, sir.
Moving on, judges, please note the next presenter is UG poster number 6. Judges, kindly note the next presenter is UG poster number 6. Hello, ma'am. Yes, your screen is visible. Am I audible, ma'am? Yes, you're audible. Thank you. Good afternoon to one and all present. The topic of my poster is MRI CBCT registered images, a novel diagnostic tool in temporomandibular joint disorders. The aim of this poster is to discuss the most reliable and accurate method to co-register MRI CBCT images for the better assessment of temporomandibular joint internal derangement, which includes the anterior disc displacement with reduction or without reduction. As we are well aware that MRI is a gold standard imaging tool to analyze the position and morphology of the articular disc, and the CBCT is a current gold standard for the evaluation of temporomandibular joints bony pathologies involving the condyle and the articular eminence and the glenoid fossa. When we merge the MRI CBCT images, there is a resultant hybrid image which is formed that combines the key features of both the MRI and CBCT images, which is used as a better identification of the disc pathologies, mainly to assess the disc position in relation to the condyle and the articular eminence of the temporal bone. So the hybrid image, which is obtained, shows areas of gray colored soft tissues and red colored hard tissues. The sequence of this image fusion, that is MRI CBCT image registration, is as follows. So firstly, we obtain the input images, that is MRI and CBCT images, by using two approaches, using markers and without using markers. The skin surface fiducial markers are used for obtaining MRI CBCT images in marker guided approach, whereas in non-marker guided approach, we generally take the normal MRI CBCT images, followed by pre-registration of the image and then transformation of the images, resampling of the MRI CBCT images to get an output image, which is optimized finally to get a fused image. There is a case which is presented in this poster, which is taken from an article of a 14-year-old female patient who is presented with pain in the left temporomandibular joint region with limited mouth opening for the past 2 days. The patient also gives history of clicking in the left temporomandibular joint during mouth opening. MRI CBCT investigations were raised. The MRI was conclusive of anterior disc displacement. Also, there were some bony abnormalities which was noticed in the condyle. So CBCT was also raised. The CBCT concluded that there were no bony pathologies or bony abnormalities seen. Only there was obliteration of the disc space and there was anterior disc displacement, which was also appreciated. So from finally, a fused image of MRI CBCT was obtained by image registration process using fusion algorithm, and it was concluded that the anterior disc displacement was there. Also, the bony structures were normal, which was suspected as a bone defect in MRI image. To conclude, the MRI CBCT registered images aid us in a three-dimensional reconstruction of the temporomandibular joint for the assessment of temporomandibular joint derangement. Thank you. Over to the judges.
Nice topic, doctor. Is it a static image or a dynamic image?
It is a dynamic image. It's a three-dimensional. So the image can be reconstructed in a three-dimensional plane. All the three orthogonal planes, like axial, the coronal, and the sagittal planes.
I think you have misunderstood, because dynamic, it is like there is an MRI scan where you can do a dynamic scan where you will tell the patient to open and close the mouth during an MRI scan. Okay, so you get to know how the mouth is opening, where the disc is moving, whether it's moving anteriorly, whether it is getting displaced, whether there is with reduction or without reduction. All that clarity you get with an MRI where there's a dynamic scan. When you're trying to superimpose something, a dynamic image would be very difficult to superimpose. Okay. So
yes, sir.
I think it would be a static image. Are you doing this in your center?
No, sir. So
have you personally seen any of these cases?
So there is many systematic review articles which were conclusive that this could also be an additional diagnostic tool in the diagnosis of anterior disc derangements. Because
this is a theoretical thing, or is there a practical way of doing this? Is there a software available? I'm really interested. I would like to know.
So there is actually a software, but still it is under study. This is reliable, but still there is a study. This study is not conducted in India. It's a study which is conducted in USA.
Okay, so you've taken it from an article. The whole presentation is from an article, right?
Yes, sir. So it is based on a single review article. So which also had it, which also has some sub articles for its reference and for its reliability.
Thank you, Doctor. Thank you.
Thank you, sir.
So you haven't put the reference again, have you? I can't see.
No, ma'am.
So have they mentioned any indications, or can it be done routinely for all the cases?
Ma'am, the main advantage of
MRA CBCT image registration is that we can determine the position of the articular disc in relation to the bony components like the condyle as well as the articular eminence. So it is indicated in disc derangement, especially the anterior disc displacement. So whether it is like it can be mild, moderate, or whether there is full displacement of the articular disc. And also bony pathologies like the degenerative joint disorders, like even osteoarthritis, the osteophytes, and also soft tissues like synovitis could also be appreciated from this.
Okay, since you emphasized anterior displacement, what is posterior displacement? Just out of curiosity.
Anterior, there is change in the position of this.
It's okay, no problem.
Thank you, ma'am.
Thank you. Judges, please note the next presenter is UG poster number 7. Judges, kindly note the next presenter is UG poster number 7.
So post number 5 is not there.
Ma'am, poster number 5 and 4 is not there.
Oh, okay, 4 and 5. Okay.
Moving on, judges, please note the next presenter is UG poster number 8. Judges, please note the next presenter is UG poster number 8.
Ma'am, this is OMR poster 8.
Please share your screen.
Is this visible?
Yes, it is visible.
Okay, good evening all. Our topic is nanotechnology in industry. So nanotechnology is a manipulation of matter on a molecular and atomic level, and it has the potential to bring enormous changes in the field of medicine and industry. Mainly consisting of nanorobots, nanomaterials, and biotechnology. Nanorobots is an essentially and controllable machine at a nanometer or molecular scale that is composed of nanoscale components and algorithmically responds to input forces and information. It's mainly consisting of nanorobots for tooth repair, nanorobots in dendrifices as dendrifine robots, nanorobots, orthodontic robots, and nanorobots for anesthesia. Nanorobots for dendrifice is mainly delivered either by mouthwash or toothpaste, can cover all subgingival surfaces, thereby metabolizing trapped organic matter into harmless and odorless vapors. And it can also identify and destroy pathogenic bacteria that exist in the plaque and elsewhere. And this invisibly small dendrifites are purely mechanical device and that is safely deactivate themselves when siloed. So orthodontic robots are also painless tooth upbringing, rotating, and vertical repositioning, as well as rapid tissue repair. And this new stainless steel wire that uses nanotechnology is being studied that combine ultra high strength with good deformity corrosion resistance and surface finish. And nanorobots for anesthesia. It increases, it contact with the surface of the crown or mucosa can reach the pulp via gingival sulcus, lamina propria, or tendinous tubules. Once in the pulp, they shut down all sensation by establishing control over nerve impulse traffic in any tooth that require treatment. And after completion of treatment, they restore their sensation, hence producing anesthetic effect. So this is an anxiety-free and needleless comfort. Next is nanomaterials. Nanomaterial mainly consists of nano needles for cell surgery, as minute surgery, which is nanosized stainless steel crystals incorporated in suture needles, and nano composites, nano impression materials, and nanomaterial for bone replacement material. Example, osteum etching. Nanomaterials, nanocomposites mainly small milliparticles, which is necessary to improve polishability and aesthetics of the restoration, and also nanomaterials, and also for treatment. Next one is nanoshells for cancer treatment. It is nanoshells, which is an minuscule beads, are specific tools in cancer therapeutics, and this nanoshells has an outer metallic layer that is cell intact, and they selectively destroy cancer cell while leaving normal cell intact. And this also brachytherapy is an advanced form of cancer treatment, which is still under trial. And other use of nanovectors is using drug delivery across the blood-brain barrier in the treatment for Alzheimer's and Parkinson's disease. Thank you.
Thank you. Over to the judges.
Okay, what is the size of the nanoparticle?
It's an 1:18,000 diameter of human hair.
Pardon?
1/80,000 of the diameter of a human hair. It's mainly nanometer ranges from 1 to 100 nanometer.
Pardon, I didn't get you.
It's mainly nanometer ranges from 1 to 100 nanometer. And also about 1/18,000 of the diameter of a human hair.
Okay. So how do you deliver it?
It's mainly dendrifies mainly delivered by through mouthwash.
Okay, for cancer therapy? You mentioned about cancer therapy, right?
Yes, ma'am. It's mainly
you mentioned some vector, right?
There's minuscule beads, like it's a minuscule beads.
Minuscule.
It's in.
Okay. How does it reach there?
It's mainly
It's okay. It's okay, Arvind.
Doctor, is there any adverse effects for nanobites?
It's mainly there's engineering challenges, social challenges, mainly social acceptance, aesthetics, and public acceptance mainly. And also it has a biological challenges, that is if any causes any problems to human body, or it may be developing a bio-friendly nanomaterial. And also its production feasibilities and hazards mainly caused with nanorobots.
Is there any documented hazards that as such that's what I'm biological?
It's an ongoing project. Mainly the variation in environment, there is temperature, pH, or different biological condition or other pollutants may cause some changes in this nanorobots, which is mainly controlled, and it may causes harmful effect to human health and environment.
Once delivered, it will be there, or is there a way that you extract it off?
Mainly dendrifi robots, it's deactivate themselves when shallowed.
Thank you, Doctor.
Thank you. Judges, please note the next presenter is UG post number 10. Judges, please note the next presenter is UG post number 10.
Hello. Am I audible?
Yes, you're audible.
Okay. Can you see the presentation?
Yes, we can see the presentation.
Okay. Good afternoon. Today, I would like to present a poster on the topic, the oral repercussions of stress. The effect of the stress on oral health starts unconsciously unless and until you feel pain or see any damages in teeth. The signs of the stress in oral cavity include poor oral hygiene, aphthous ulcer, xerostomia, bruxism, burning mouth syndrome, TMJ disorder, and oral lichen planus. First, coming to the poor oral hygiene. Neglecting the brushing and flossing due to stress leads to dental caries, gingivitis, and periodontitis. Next one is the aphthous ulcer. It's also known as Kango sores. It's a painful ulcer which occurs due to increased salivary cortisol level. Next one is the xerostomia. It occurs as a result of increased salivary cortisol level during the stress, resulting in salivary gland hyperfunction. Next one is the bruxism. It mainly occurs due to clenching of the jaws, resulting in unconsciously grinding teeth, leading to tooth fracture. Next one is the burning mouth syndrome. It's a common dysesthesia, typically described by the patient as a burning sensation of oral mucosa in the absence of clinically apparent mucosal alterations. Next is the TMJ disorder. It is resulted from the bruxism, popping, clicking, sound of TMJ with deviation. The last one is the oral lichen planus. It's a chronic inflammatory disease of the oral mucosa. Many authors believe that among patients with mental disorders such as depression or psychological stress, changes in the immune system may also lead to oral lichen planus. Skipping oral health routines can have a negative impact on both our dental health and well-being. Understanding the signs and symptoms and the impact that the stress can have on our health is very important. Thank you.
Thank you. Over to the judges.
So you are telling there is increase in the salivary cortisol level, right?
Yes, ma'am.
So most of these conditions, especially after ulcer or lichen planus, etc., you give hydrocortisone or tenavate or whatever. It's a corticosteroid that is given, no?
Yeah.
So don't you think it is an oxymoron, something contradictory? Already so much of salivary cortisol, and then you are giving a cortisol.
Ma'am, I didn't get you.
No, cortisol level is increased. That is the cortisol steroid, right?
Yes, ma'am.
And you are giving corticosteroid for the as treatment also, especially like in planus, you give steroid only, no?
Yes, ma'am.
Initially. So why this? Already it is increased, and then you're giving externally also steroid. Have you ever thought why?
Okay.
Most of these conditions, steroid works also, isn't it?
Yes, ma'am.
You mean to say that the cortisol level increases causing salivary hypofunction, or you mean to say salivary cortisol or cortisol levels in saliva increases?
Sir, the cortisol level in saliva will increase.
I think ma'am is asking you specifically that now all these conditions where you're saying that salivary cortisol levels are increasing, in lichen planus, all these kind of treatment that we do is we are giving steroids to the patient, right?
Yes,
to
sir.
reduce the inflammatory component and also to modulate the immunity, right? So when you're doing that, is it not contradicting that cortisol level increasing causing these problems, and again we are treating it with again steroids? That is what I was asking.
Okay, sir. I don't know.
Okay, it's okay. You find out.
PMJ disorders, can you just tell it again? What is that causing? How stress is associated?
Sir, during stress, we used to cleanse and grind our teeth, so it can lead to tooth fracture, and it can also result in TMJ, popping, clicking sound, and deviation, and also.
Can understand, bruxism causing issues to the joint disc. Okay.
Yeah.
Why have you specifically written TMJ with deviation?
Yes, I don't know, sir.
Okay, okay, doctor. Thank you.
Okay, that's okay.
Thank you. Judges, please note the next presenter is UG post number 11. Judges, please note the next presenter is UG post number 11.
Sorry, the last presentation was question number 10 or 9?
Yeah. 10.
See, let me just re-clarify. We had missing question number 5, 7, and 9, right?
Yes, sir. Four was missing, no?
Yes, sir. 4 was missing, 5, and then 7 and 9.
Okay.
Am I audible? This is post 11, number 11.
Yeah, you're audible.
Is the presentation is on the screen? Is it visible?
Yeah, it's visible.
Okay. Very good afternoon, everyone. This is post number 11 titled Nano Drug Delivery System in Treatment of Oral Squamous Cell Carcinoma. According to World Health Organization, oral cancer is the 13th most common type of cancer globally. In India, it is the second country having the highest number of oral cancer cases. Oral squamous cell carcinoma is the most common oral malignancy, representing up to 80 to 90% of all malignant neoplasms of the oral cavity. Many treatment strategies have been employed for the treatment of cancer, such as surgery, radiotherapy, chemotherapy, either alone or in combination. Though these strategies had improved the survival rate of patients, Yet, they do have certain limitations, such as non-specific site of action, due to which they lack the inherent ability to differentiate between normal and tumor cells. To overcome these limitations, new advances in drug delivery system is introduced through nanoparticles. Nanoparticle drug delivery systems are engineered technologies that use nanoparticles for targeted delivery and controlled release of therapeutic agents. Commonly used nanoparticles are liposomes, polymer particles, hydrogel particles, dendrimers, metal particles, etc. Looking into the mechanism, structurally, there are evident differences between the normal tissue and the tumor tissue. Capillary of tumor tissue has porous structure and pore integrity compared with the normal tissue. Lipid particles and macromolecules leak from the capillary and they cannot flow back into the blood, which leads to the retention of these molecules in tumor. This phenomenon is called as enhanced permeability and retention effect. Nano drug delivery system utilizes this effect to produce a drug carrier transport system within a nanometer size range, which can also be used for targeted therapy of nanodrug carriers. Nanoparticles targeted drug delivery systems can be done by passive targeting, where it enables the drug to deliver to the tumor site by modifying and adjusting carriers. And in active targeting, it modifies the surface of the carriers through specific ligands. And in immune targeting, a vaccine with tumor antigen is infused into tumor patient to stimulate the body to produce antibody to immunize the tumor cells. In magnetic targeting, magnetic nanoparticles are used to enhance the effect of chemotherapy. Nanoparticle drug delivery system has many advantages over the conventional methods. It has sustained drug release, effective drug loading, improved biocompatibility, less systemic toxicity, better anti-tumor efficacy, improved patient compliance, precise targeting of tumor site. To conclude, nanoparticle drug delivery system is still in continuous updating. Even though it offers many advantages, there are still many limitations to be solved, such as instability in circulation, inadequate tissue distribution, and toxicity. A future perspective is also recommended to highlight the existing challenges and possible resolution for the treatment of oral cancers. Thank you.
This can be used for other types of cancers as well, other than oral squamous cell carcinoma?
Yes, sir. Presently, it is approved for ovarian cancer and breast cancer. It can be used.
Salivary gland.
Yes, sir. It can be used.
So it's a chemotherapeutic drug that you are enhancing with this modality, right?
Sir, this nanodrug delivery system can be used in combination therapy or can be used alone. So it can be used with chemotherapeutic drugs also.
So does the carrier change for different tumors?
Yes, ma'am. It depends upon the, as I've explained here, this enhanced permeability and retention effect. It mainly depends upon the location of the tumor, status of the blood perfusion, and other macromolecular changes. So based on that, we can use, and it can be used for diagnosis also. For example, iron oxide particles can be used for the detection of cancers when we use MRI scan and all. So these nanoparticles can be used.
So how do they decide that I have to go and concentrate on this particular tissue? It has to be guided, no? So radioactive materials are used, no? So when it is for thyroid, they use iodine, radioactive iodine, and in some other areas they use. So the target organ, what the organ accepts, that has to be used, no? So anything similar in this nanotechnology? If it is tongue oral squamous cell carcinoma, it has to go to the tongue and get lodged there, right? If it is
Yes,
ovarian cancer, it has to go to the ovary, not the tongue.
Yes.
So
Yes,
how
yes.
does it decide? I have to go to this place and not the other place.
I'm sorry, ma'am. I'm not aware of this.
It's okay. It's okay. No,
Just put it in
telling.
full screen just once.
Yeah, half the screen only is visible. No?
Ma'am, there was technical issue, so I couldn't share it in PPT mode. I have put it in PDF mode.
Okay, okay.
So I'll
Then
just
reduce it. Then reduce the size so that we can see full. So that
it can be done only this
full thing
much.
can be seen together, no? We are seeing it in pieces. That's why. It's okay, no problem.
Sorry, ma'am, I couldn't do it.
Okay, good.
Let's move on.
Okay, is it fine, ma'am? Okay.
Yeah.
Thank you. Thank you.
Thank you. Judges, please note the next presentation is UG poster number 12. UG poster number 12.
Am I audible?
Yeah, you are audible.
Is my screen is visible?
Yeah, it's visible. You can proceed.
Thank you. Good evening, all. My topic for today's poster presentation is oral cancer diagnostic, gauging the crack. Commonly used or optical methods for the diagnosis of oral cancer are optical coherent tomography, Visilite, Bell scope, microlex DL, identity, narrowband imaging, and Raman spectroscopy. Light-based imaging of the tissue detects minimal changes such as cell and microanatomy, expression of specific biomarkers, tissue architecture, chemical changes, vascularity, or angiogenesis. These properties are ideal for the early detection of oral cancer. Coming to the first optical method, optical coherent tomography. Optical coherent tomography, it is a non-invasive optical method. Its non-invasive nature, along with a penetration depth of 2 to 3 millimeter, high resolution, real-time image viewing, and the capability of cross-sectional as well as 3D tomographic image, provide excellent prerequisite for in vivo oral screening and diagnosis. The resulting opti-image leads to visible epithelial thickening, loss of epithelial stratification, and epithelial downgrowth. Next optical method is a Visilite. Visilite, it is a chemiluminescence optical method. After rinsing with an acetic acid mixed solution, the oral cavity is examined under chemiluminescent illumination at 430, 540, and 580 nanometer wavelength. The detector signals may be related to the altered thickness of the epithelium or to the presence of higher density of nuclear content and mitochondrial matrix that preferentially reflect light. Hyperkeratinose or dysplastic lesions appear distinctly white when viewed under a diffuse low energy wavelength light. Coming to well scope, it is an autofluorescence optical method. When viewed through the instrument eyepiece, normal oral mucosa emit a pale green autofluorescence upon stimulation with intense blue excitation at 400 to 460 nanometer wavelength, while dysplastic lesions exhibit decreased autofluorescence and appear darker with respect to surrounding healthy tissue. It shows high sensitivity and also but low specificity. But when using along with the histology, so when used along with histology and well scope, it leads to high sensitivity and it provides high sensitivity and high specificity. Next one is a microlex DL. Microlex DL, after rinsing with the DL, that is a diagnostic light solution, irregular cells will take on a white hue due to the change in cell structure. Coming to Identify 3000. Identify, it is a multispectral screening device that incorporates 3 different light which are designed to be used in a sequential manner to facilitate intraoral examination. In addition to LED white light, Identify also used violet, green amber light to induce direct tissue fluorescence and tissue reflectance. As a result, biochemical changes can be monitored with fluorescence, while morphological changes can be monitored with a reflectance. Coming to narrowband imaging. Narrowband imaging, based on the wavelength particle duality, through the propagation of the light through the tissue, it causes red light, splitting of red light and blue light. This red light diffuses widely and diffuses deeply due to the longer wavelength, and it causes in this light the mucosa capillary has a brownish appearance, and the blue light diffuses smaller range due to shorter wavelength, and it causes the it leads to the submucosal vessels can be seen as cyan or blue appearance. Coming to the last optical diagnostic method, that is the Raman spectroscopy. It is an optical method that is both fast and simple. It is one of the most widely used technique for the non-destructive categorization of molecule and material. The Raman spectroscopy probes the vibrational mode of a molecule, which are sensitive to its chemical bond and provides a unique fingerprint that enables identification of chemicals. This inelastic light scattering arises from the, it shows the inelastic light scattering arises from the molecular vibrations. Coming, why we should use this optical method for the early detection of oral cancer? The advantages are it detects minimal or early changes. Repeated, it can be used repeatedly. That is, repeated non-invasive monitoring is possible, and also for rapid examination. Even though it has many advantages, it also has some of the limitations, that is the disadvantages. That is, analysis of some small sample size lesions is not possible. Lack of methodological sound clinical trials not possible. Insufficient use of histological and molecular mapping of optically altered mucosa is not possible. Here comes the end of my poster. Thank you.
Doctor, do you know what is specificity and sensitivity?
Specificity means to diagnose or detect that specific lesions. Ability to designate that this two lesions. Or
You should look into it, doctor. Next thing, okay, which of these technique has highest specificity and sensitivity?
Narrowband imaging has the highest specificity and sensitivity.
Are you telling this from a literature or?
So from the article.
Over to you, ma'am.
When you want to tell this is definitely the lesion, you'll use a highly specific test or a highly sensitive test. When you go for a screening, which test will you use? Highly specific or highly sensitive? Just a modification of what Arvind was asking.
Highly sensitive test.
For
screening, ma'am.
And why? When you use something, you should know why you are using it, right?
Ma'am, because even a small lesion has to be.
And many of them will not show you this. The small lesions cannot be determined. That's what you are telling.
Ma'am, early lesion has to be diagnosed, no? So sensitivity has to be.
Okay, no problem.
Thank you. Judges, please note the next presentation is UG poster number 13. UG poster number 13.
Hello.
Am I audible?
Now you're audible.
Put it in the slideshow.
Okay. Good afternoon. My topic is CRISPR-Cas9 genetic scissors. CRISPR is a family of DNA sequence that is found in the genomes of prokaryotic organisms such as bacteria. So in a document, if we suspect we have any misspelled word, we can use find function to highlight the error and correct it or delete it. Likewise, within our DNA, that function is taken on by a system called CRISPR-Cas9. So what is CRISPR? It is clustered, regularly interspaced, short palindromic repeats. It is a genome editing tool enabling researchers to precisely manipulate specific genomic elements and facilitating the elucidation of target gene function in biology and diseases. So this CRISPR consists of two components, Cas9 protein that can cut the DNA, and guide RNA, which consists of CRISPR RNA and transactivating cRNA. That is to recognize the sequence of DNA to be edited. So how does it work? First, we'll identify the sequence of human genome that is causing the health problem. Then they create a specific guide RNA to recognize that particular stretch of DNA. This guide RNA is then attached to the DNA cutting enzyme that is Cas9, and this complex is attached to the targeted cells. It locates the targeted letter sequence and cuts the DNA and edits the existing genome by either modifying, deleting, or inserting a new sequence. As such, it effectively makes CRISPR-Cas9 a cut and paste tool for DNA editing. So applications in dentistry, it can be used to treat oral cancer, dental caries, dental plaque, helps in the tooth and cleft development, also treating the TMJ disorders, salivary dysfunction. So coming to the advantage, it is efficient and easy to use, precise gene editing, target specific and multiplex genome editing. Coming to the limitations, it has off-target effects, delivery efficiency, and then genetic drive, that is, it is passed from one generation to the next generation. So to conclude, this modern technology has many potential uses and is standing on the brink of modern medicine, which could do a lot in the future of oral health. Thank you.
What is the basic principle of this? How does it work? Principle. Can you hear me? Hello?
There is a guide RNA. Hello?
Tell. I can hear you.
There's a guide RNA, and this guide RNA is attached to Cas9 protein, and this is injected into the cells, that is mutated cells.
Then?
This DNA, they can be deleted or modify the genes and resulting in a new DNA which is not having any cancerous cells.
Okay, how does the gene therapy work? Usually. How does it work usually?
That is by when we are injecting the this complex into the cells, we are either cutting or deleting the unrequired nucleotides from the DNA, and the required DNA components are either added or deleted or inserted or modified to form a new required DNA.
Do they replicate?
Which one, sir?
The new thing that you have inserted and that you have produced a new one, no?
Yes.
How does it work?
This can be passed from one generation to other.
Oh.
When is this intervention done? Is it in the neonatal stage? What stage is it done?
No,
When is this intervention?
No, we can do after, if there is a cancer, to that cancerous cells, we can add these this complex, and we can make changes in the already present or affected cancerous cells. We can make the changes in that.
So this can be done at any stage of life, right? Imagine a case you had an application in dentistry where you said cleft lip, cleft palate, right?
Yes, sir.
So when is this intervention done? Whether it is, you predict the probability of getting a cleft lip or a cleft palate by looking at the, mutilated cells, or how is it done?
By injecting this, we can there can be tooth regeneration can take place if injecting this complex, we can get a new tooth regeneration can be made.
My question is, when is this
Get
intervention
the question.
done? Yeah.
At what stage? Intrauterine, extrauterine? Because now anomaly scanning, everything is available, no? So that's why it's asking.
That I am not sure. Sir.
Okay, doctor. Yeah, thank you.
Okay, thank you.
Thank you. Judges, please note the next presentation is UG poster number 14. The next poster is UG poster number 14.
Good evening, ma'am. Am I audible?
Yeah, you are.
Shall I start? Hello, ma'am. Shall I start?
Yeah, you can start.
Good afternoon, everyone. My co-delegates. My topic is artificial intelligence in dentistry. In the last 2 decades, artificial intelligence has shown spectacular development and growth over the past 2 decades. Now let's get into what is artificial intelligence. Artificial intelligence is a simulation of human intelligence processed by machine, especially by computers. Types of artificial intelligence is ANI. It's artificial narrow intelligence. Artificial narrow intelligence is nothing but Siri, Google Assistant. It is all called artificial narrow intelligence. Artificial general intelligence. It is smart like a brain, human brain. What human know, it can replicate. It is artificial general intelligence. Artificial super intelligence is much more smarter than the smart human brains. It can detect what human even can't detect. Okay, for the artificial intelligence, focus on 3 cognitive states. It's learning, reasoning, self-correcting. Reasoning means artificial intelligence can make their own judgment. Okay. Branches of artificial intelligence, that is machine learning and deep learning. In medicine, we are using only 2, machine learning and deep learning. Machine learning is nothing but the system can identify the pattern. For example, if you show the child a couple of cats, the child can identify the cat without any assistance. This is the principle of machine learning. In deep learning, if you show a couple of cat pictures for child can identify the hair, eyes, nose, and ears of the cat, and it can identify okay, this is a cat. This is the principle behind deep learning. The algorithm we are using in medicine is CNN and ANN. CNN is convolutional neural network and ANN is artificial neural network. Artificial neural network consists of 3 layers: a hidden layer, input layer, and output layer. Hidden layer is nothing but there will be no result, or it is hidden. Are the challenges of artificial intelligence. Secure data sharing will not be mostly available in artificial intelligence. Questionable medical ethics. It doesn't follow the ethics of medicine. And artificial intelligence in now it got in artificial intelligence in dentistry. In radiology, CNN algorithm is mostly used, and ANN also used. CNN demonstrated 95 to 99.8% accuracy in detecting and identifying teeth with the carious lesion, teeth with abnormalities. It can even detect the white spot lesion. It can even detect the teeth is going to be get affected by that streptococcus viridans. Like, and in orthodontic, ANN is used in decision making process and treatment plan. It can even show the outcome of the treatment of the patient we are going to treat. In periodontics, ANN was 90 to 98% accurate in classifying patient as aggressive periodontitis as chronic periodontitis. In periodontitis, implantation. Recently in China, a robot made the implant in human successfully. Endodontics, artificial intelligence is mainly used in detecting the canals, mesial canal. It's very detecting the canal, and it can identify the working length, how much we can use. Likely, it can easily detect. In oral pathology, artificial intelligence is used in detecting and diagnosis the cancer stage. When it's going to start the metastasis process, it can even detect the cancer in very previous stages also. Virtual reality in dentistry. Virtual reality is like what we are seeing in science fiction is now becoming a reality. With virtual reality, the headset or a cam can wear by patient both doctor. It is mainly used to avoid the phobia to the patient. That's all, ma'am. Thank you. Hello.
Your flow was good. The presentation flow was good. And your
Thank you, sir.
good.
Okay, sir.
Do you know any examples of CNN convolutional neural network that
neural network? Sir, in CBCT also they are using CNN only, sir. In CBCT and
no, in AI, are you aware of, have you heard of RestNet and all those things? These are softwares which would help you. Once guided, it will. This is not exclusive software, but it's like a learning platform where you can make.
I don't know, sir, but I am aware of this. In coming years, we don't need receptionist. The computer itself can appoint for patient. If the patient is not happy with the doctor, and the computer itself can change the doctor.
So that's good news.
Hello. Do you think if you use artificial intelligence, you will be replaced by artificial intelligence? You don't have anything to do. Do you fear about that? In future, you don't have anything to do.
Maybe yes, ma'am.
Sure.
It's artificial intelligence. There is a threat to dentistry, ma'am. Yeah, in future, no need of dentist to do extraction, implant. Even a robot can do, ma'am.
But somebody has to manipulate that, no? So definitely,
that is a very small.
A knowledgeable person has to be there.
Yes, ma'am, but it's comparatively very small work.
Okay. What is vertopsy? Any idea?
Ma'am?
Vertopsy.
Vertopsy. No, ma'am.
It's related to artificial intelligence only.
We have a lot of paper on forensics. So
yeah.
No, yeah.
It's okay, no problem.
Okay, ma'am.
Thank you.
Thank you.
Judges, please note the next presentation is UG poster number 15. Poster 14, kindly mute your mic. Poster number 14, kindly mute your mic.
Ma'am, I'm audible.
Yeah, you are audible.
My slide is visible to you.
Yeah, you can proceed.
So can I start with my presentation?
Yes, sure.
A very good afternoon to all the delegates and the jury members. Today, I'm going to present a poster on low-level laser therapy, untapped resource in dentistry. It is also known as phototherapy or photobiomodulation, a potential non-invasive technique. It is a useful alternative or supplementary tool to treat various oral maladies by which it increases patient comfort and clinical outcomes. Now, the uses in the dentistry, specifically in the oral medicine, it is used in the temporomandibular disorders and the orofacial pain, recurrent aphthous ulcers, or even in the case of traumatic ulcer, oral mucositis, in the case of salivary disorders like xerostomia, hypersalivation, in oral lichen planus, trigeminal neuralgia, burning heart syndrome, and leukoplakia.
ஆன்சர் பண்ணி அட்டெண்டன்ஸ் பண்ண எனக்கு போட்டு மோஸ்ட்லி நாளைக்கு வரமா
Now we come to how low-level laser therapy works. Laser light of wavelength 680 to 900 nanometer is delivered to the tissue via probe in a contact mode with the surface of the skin. Then the light enters the cell mitochondria and is absorbed by chromocytes, including the protein cytochrome C oxidase, which then increase its activity. As a result of heightened activity, 3 molecules are affected, that are ATP, reactive oxygen species, and nitrous oxides. ATP, it is the main source of the energy source of the majority of the cellular function. It is also called as the energy currency of the cell. It increases the cell ability to fight infection and start the healing process. Reactive oxygen species, modulation of reactive oxygen species activate transcription factors positively, impacting cellular repair and healing. Then the nitrous oxide, a potent vasodilator, increases circulation, decreases inflammation, and enhances the transport of oxygen and immune cells throughout the tissues. Now, we have different types of LLT used. The most common type of LLTs we use are CO2 laser, uses carbon dioxide, and DYAG laser, using neodymium doped crystals, then the yttrium aluminum garnet YAG crystals. Then the physiological effects of LLTs are angiogenesis and neovascularization, collagen production. It increases muscle regeneration and muscle atrophy, bone formation, cartilage production. It also enhances the nerve regeneration and reduces the inflammation and the edema. Now, what are the benefits of the LLTs? It reduces the level of pro-inflammatory enzymes, thus helping with both the inflammation and the pain. Allow the body to heal without medication. It's safe, natural, and effective alternative. Increase immunity, promoting faster recovery. Not only address the symptom experience, but also the root problem. Then, now, what are the contraindications? It is contraindicated in cardiovascular disorders, in pregnant women, in all the carcinomas, in epileptic patients. Then, LLT can provide patient with a wide range of therapeutic advantage, including faster wound healing and pain elevation. The main advantage of LLTs, low-level laser therapies, compared to other treatment options is that it can be used for the various oral maladies, as I mentioned earlier, without having any side effects and without the risk of medication. Overdose, especially in the older population that is becoming very of overprescription of medicine, which frequently have hazardous and severe side effects. it is a benefit to the dental practitioner and patient to investigate photobiomodulation, an untapped and underutilized resource in dental industry. And further research, especially randomized controlled clinical trials with long-term follow-up, are needed to know the use of laser therapy for the prevention and the treatment of many oral disorders. As I mentioned, there is a contraindication in pregnant women, carcinomas, epileptic patient, and a patient having thyroid or serious disorder. But in some cases in usual cases, when we do laser therapy, one thing we should be cautious about the eye protection. We should wear the patient and the practitioner both should have to wear the ear mask and eyes mask, and they don't have to use loops. In this picture, I have shown the LLT device equipment. That's all. Thank you, ma'am.
Which of this type is really beneficial? Which one do you prefer for an L&D purpose?
Sorry, sir, can you repeat your question?
Which of this low-level laser therapy would you specifically prefer? Is it a carbon dioxide or FDM or?
Sir, they have different modalities in different diseases. Most probably CO2 lasers are most commonly used. And for the TMJ disorder, ND-YAG lasers are more preferred.
How does it act in trigeminal neuralgia?
So in trigeminal neuralgia, they nerve sensation. So they act on the nerve. Specifically in the trigeminal neuralgia, there are nerve sensation. So they help in regeneration of the nerves.
They help in regeneration of the nerves or pain suppression?
So they help in the suppression also. After that, they also help to nerve to heal.
How does the normal light and the laser light differ?
Sir, ma'am, it's laser act as like a pencil.
No. What is the basic difference between normal light and laser light? If you put the normal light, nothing will happen, no?
Yes, ma'am.
So that is also light. This is also light.
Yes, ma'am. Ma'am, laser light are monochromatic and directional also.
Directional, you have to add something before that. Before directional, some prefix is missing. Three properties.
Ma'am, there are three properties like monochromatic, it is coherent and directional.
Directional.
Unidirectional or?
Yeah. So which all lesions you should be careful in using photobiomodulation?
Ma'am, can you repeat your question?
Which all lesions you will be careful in using photobiomodulation? You have to be extra careful when you're using it. You have listed so many lesions, right?
Yes, ma'am.
In those, you have to be a little careful when you're using laser therapy. Which one?
Ma'am, I should mention the first, in the case of mucositis, because it is because of the radiotherapy or the chemotherapy. So in that case, we should be very cautious because the patient is already in such condition and
so you're giving a palliative therapy in that, no?
Yes, ma'am.
Then why you have to be so cautious? It's good for the patient rather than applying any cream or taking medication.
Yes, ma'am, any systemic medication.
Yeah, rather than that, photobiomodulation is better, no?
Yes, ma'am.
Then?
Ma'am, because it has any, it does not has any side effects.
No, my question, you didn't get my question. Which condition you will be more careful, cautious in using photobiomodulation?
Ma'am,
In between, you told something, but I just want to know whether you have understood it properly and then mentioned it, or just by-hearted it. That's why, because this is very important. Nowadays, everybody's left, right, and about turn are using low-level laser therapy. That's why.
Yes, ma'am. Ma'am, in case of pre-malignant lesions, we should be cautious. Ma'am, in case of pre-malignant lesions, we should be cautious.
Yeah, exactly. So how will you decide whether you can use laser therapy or not?
Ma'am, first we have to know it is a pre-malignant.
How do you know?
Ma'am, we
You're
have to
correct.
differentiate between the malignancy and the pre-malignancy. Then only we can.
How will you know clinically? How will you know that this is pre-malignancy and this is malignancy? It's not possible, no?
Yes, ma'am.
The cases. So how do you know?
Ma'am, we go for the various investigations.
Means be specific. It's okay, no problem. You do a biopsy and see, no?
Yes, ma'am. But biopsy, ma'am, in biopsy, it is an invasive process. We remove the tissue.
Only when you have a suspicion.
Yes,
then
ma'am.
Definitely you'd have to go for biopsy.
Biopsy, yes, ma'am. It's a gold standard.
Yeah. It's okay.
Okay, thank you, ma'am. Sir, any question?
No, I was wondering why you had mentioned it as untapped resource in dentistry. Because like ma'am said, now laser is being very widely used, right? And it's one of the very beneficial, yeah, but I do understand that there might be areas where, laser may not be used that much. Okay, thank you, doctor.
Okay, thank you, sir.
Thank you. That was poster number 15. Judges, please note the next poster is UG poster number 16. UG poster number 16.
Yes, ma'am. Am I audible?
Yeah, you're audible.
Is my screen visible, ma'am?
Yes.
Good afternoon, everyone. I'm going to present a topic about dry needling in management of myofascial pain associated with temporomandibular disorder. So here is just an intro for TMD. TMD is a group of many conditions that cause pain and dysfunction in jaw joint and muscles that control jaw movement. Due to chronic facial pain, it may immensely affect health-related quality of life. Common symptoms with which they present are pain and tenderness on palpation, limited jaw movement. Common treatment modalities that are being followed to treat this condition include pharmacological and non-pharmacological methods. Let's see about today's revolutionary pain relieving procedure. That is our topic, dry needling, where a filiform needles are trapped through the skin to target tissue to bring about therapeutic effect. No medicine is delivered in here, so that is called as dry. Basically, the theory of treating myofascial pain from TMD, which mainly include masticative methods and can be explained by trigger point model. Here, the myofascial pain originates from the myofascial trigger point, deactivating it by needling is the management, causing release of contractile knots, stopping the acetylcholine release, promotion of healing by tissue growth factor, pain control by endorphin and dynorphin. Here, the choice of needle is based on the target tissue, where a disposable filiform sterile needle is advanced perpendicular into the involved muscle after precise palpation. Patient is asked to perform maximum opening to avoid bony structures and is kept in for a span of 30 seconds to few minutes, where local twitch response is elicited. And the indication when there is a pain of muscular origin, therapeutic effects or advantages of this method include improved range of motion, increased pain pressure threshold, and increased blood supply, and the reduction in spasticity. Side effects also include like bruising and temporary soreness and skin irritation. By this time, everyone will be wondering, then what is the acupuncture? It is nothing but a system of complementary medicine where needles are inserted along lines of energy, myofascial meridians, and are left in body for some time. Whereas in dry needling, they stimulate a specific trigger point and removed after a short span of time. So basically, acupuncture unblocks energy meridians and creates balance and flow of energy throughout the body. And it is called as Qi, as in a Chinese medicine. In dry needling, it treats the pain and immobility by focusing the trigger point. So in terms of conclusion, trigger point is like fire alarm, kind of adjustment that the body makes. As a clinical therapist, you have reduced the muscle spasm today, taken away the patient's pain and improved range of motion. The next day when patient comes back with similar spasming altogether in different muscles or another part of the body in kinetic chain, that is because the root cause has not been administered. So dry needling is never a standalone form of therapy. It always needs to be backed up by some real exercise. So to sum up, with proper judgment and precision, dry needling is a powerful tool, quick and cost-effective treatment, which when indicated produces immediate pain relief. Thank you, ma'am.
So what is the basic principle of dry needling?
Ma'am, basic principle we are deactivating the myofascial trigger points, ma'am, by needle manipulation.
Actually, it increases the threshold.
Any questions, ma'am?
Huh?
Ma'am?
Pardon? Hello?
Can you hear me, ma'am?
Yeah, I can hear you. No, Aravind told something. No?
No. Any questions, ma'am?
Yeah, that's what I asked. What is the basic principle?
Ma'am, the basic principle.
No, you answered, no?
Yes, ma'am.
Actually, it increases the pain threshold.
Yes, ma'am, increasing the pain threshold.
Okay.
You need to be specifically trained to identify the trigger point.
Sir, can you come again, sir?
How do you identify the trigger point? Do you need a specific training or something? Or how is it?
It can be guided by using ultrasound or elastography methods that we should be combining it together. So we cannot solely depend on dry needling alone. We should combine with advanced methods like ultrasound.
So it should be like an ultrasound guided.
Yeah, yes, sir.
Are there any risks?
Yes, ma'am. It comes with the potential risk of needle stick injury and
Hello?
Contaminating with the bloodborne diseases like that. If ma'am, can you hear me, ma'am?
Yeah.
Ma'am, it comes with a potential risk, ma'am. Like needle stick injury can cause bloodborne diseases when undisposable needles are used or non-sterile needles are used.
Okay. Okay.
You can move on, ma'am.
Thank you. Poster number 16. Judges, please note that the next presentation is UG poster number 17. UG poster number 17.
Ma'am, am I audible?
Yeah, you're audible.
Good evening, all. A very warm welcome to present here about oral health and diabetes. What is diabetes? Diabetes is a chronic metabolic disease characterized by elevated levels of blood glucose or blood sugar, which leads over time to serious damage to the heart, blood vessel, eyes, kidney, and nerves. Facts about diabetes. According to statistics, there is 28% of heart attack, 90% of oral candidiasis, 20 to 30% of stroke, and 40% of new dialysis case every day. Complications include macrovascular complications, microvascular, stomatognathic complications, and infectious complications. Macrovascular include atherosclerosis, coronary heart disease, myocardial infarction. Microvascular complication includes neuropathies, nephropathies, and retinopathies. Type 1 diabetes mellitus and type 2 diabetes mellitus. Type 1 total insulin deficiency, which is less than 30 years, and type 2 produce insulin but does not properly respond to hormone in adults and children. A thorough medical history and review of psychological system should be given to the diabetes patient. By assessment of glucometer and HbA1c test, the risk factors are overweight, genetic, gestational diabetes, hypertension, and high cholesterol. How diabetes affects oral health? High levels of glucose present in saliva creates perfect environment for mouth-dwelling bacteria to thrive. Declining resistance against infection, the gum dramatically became more susceptible for bacterial infection and periodontal diseases. Oral problems which are associated with diabetes are dry mouth, bad breath, tooth decay, taste impairment, salivary gland dysfunction, oral thrush, burning mouth, and periodontitis. Preventive dental care, it increases your chances at keeping your teeth and gums in top shape. It consists of regular dental checkup, periodontal screening, and professional cleaning. Risk factors are skipping food, alcohol consumption, stress, and anxiety. What are the steps for healthy teeth? No smoking, proper dental visit, proper brushing, proper tongue cleaning, and maintaining a healthy diet. Dental treatment planning consideration. Appointment scheduling for the patient and drug use and drug interaction of diabetes. Thank you.
Okay. So what type of infection will the diabetic patient have?
Candidiasis, fungal infections, ma'am.
Fungal infections, and in bacterial infection, mostly what kind of bacterial infection? Yeah, you are not clear. Your voice is not clear.
Bacterial infections which cause periodontal diseases.
What type of infection is that? Aerobic, anaerobic?
Pneumococcal or streptococcal infections.
Aerobic or anaerobic?
Aerobic.
Periodontitis. You
Am I
have
audible?
yeah, you are. You have multiple periodontal abscesses, no?
Yes, ma'am.
In diabetic patient. That is when you suspect that, okay, this patient may be diabetic. When you see multiple periodontal abscesses in the oral cavity. Even if he is not a diagnosed diabetic, these are clues, right?
Yes, ma'am.
So these are all anaerobic infections. You have Have you heard of diabetic foot?
Oh, yes, ma'am.
That is also sort of anaerobic infection only. But people die of diabetic foot, but people don't die of periodontitis. Any reason? Both are anaerobic infections.
The leg can be deep into the veins. Ma'am, am I audible?
Yeah.
Induration of the infection through the deep veins of leg can cause death.
So why it spreads fast like that? In the oral cavity, what is there to protect?
In oral cavity, there will be dry mouth and taste impairment, and there will be salivary gland dysfunctions will be there.
No, what protects? That's what I asked. You are talking about dysfunction. That's not protection.
Ma'am, neutrophils functions.
It's okay. You have saliva, no? Which contains protective. Saliva is a protector, right?
Yes, ma'am.
What is common about periodontitis, retinopathy, peripheral neuropathy, kidney disease, etc.? All these are signs of present in diabetes, right? Is there something underlying common in all these? In nephropathy, peripheral neuropathy, retinopathy? and
Ma'am, they all
periodontal.
are related to a same nerve sheath, ma'am. The site of retina, glomerulus, and nerves. They are all supplied by small blood vessels of same nerve sheath.
So, kidney?
Kidney, yes, ma'am. Renal glomerulus is also same nerve sheath of combined with retina and other nerves.
It's not fully clear, your answer. All these organs are having end arteries, right? Okay, forget it.
There will be small.
It's okay, it's okay.
Most common sites are retina, glomerulus.
Yeah, it's okay, no problem.
Okay, ma'am.
Arvind?
Yes, ma'am.
We can move on.
Hmm?
No questions, ma'am. We can move on.
Okay, okay.
Thank you, ma'am.
Thank you. The next presentation is by UG poster number 18. Judges, please note UG poster number 18.
Am I audible, ma'am?
Yeah.
Good evening. Today I am going to present a topic, pharmacogenomics in oral medicine. Pharmacogenomics is the branch of genetics concerned with determining the likely response of individual to the therapeutic drugs. The significance of pharmacogenomics is that a patient inherited genetic makeup and their response to pharmaceutical agents are seen with regard to their metabolism. In case of normal metabolizers, they respond to normal dose of the drugs. In intermediate metabolizer, they respond to alternative therapy. And the poor metabolizer respond to high dose of drugs, and the rapid metabolites respond to lower dose of drugs. In such cases, the normal dose of drugs maybe leads to toxicity. Application of the pharmacogenomic in oral medicine. Oral squamous cell carcinoma. In oral squamous cell carcinoma, high expression of the gene SODI maybe leads to resistance to the afatinib. In the head and in a head and neck cancer, in case of acute lymphoblastic leukemia, about 10% of the people show genetic variation in the enzyme called thiopurine methyl transferase. It is responsible for metabolizing chemotherapy for the acute lymphoblastic leukemia. Children with lower thiopurine methyl transferase level receive lower chemotherapy doses. This helps to prevent severe side effects. It is also used in case of herpes and the bone resorption such as periodontal diseases and the chronic oral and the facial pain, and management of autoimmune disorders and the TMJ. Benefits of pharmacogenomics: effective drug formulation, improve safety of drugs, increase potency of drugs, improve patients' care and compliance, right selection of drugs, and improve drug elimination. And the goals of pharmacogenomics include maximize drug efficiency and minimize drug toxicity, predict patient who will respond to intervention, aid in new drug development. In conclusion, that pharmacogenomic data can greatly help us to understand the variability in the drug response from person to person. This will in turn lead to improved safety and efficacy during the new drug development process. Thank you, ma'am.
So, how do you decide this? Which drug at what dose is to be given to which patient? How expensive it is?
Ma'am?
How expensive it is to decide through pharmacogenomics to decide which drug to be given to which patient at what dose?
It depends upon the metabolism of the patient.
So how do you decide that? How do you find out that metabolism?
Based on the genetic test, DNA profiling.
Okay, that's why I asked how expensive it is. Can it be routinely used?
Nowadays, it is not routinely used, ma'am, but in future it may be used.
Okay. Okay.
So is there any live little data on development of any drugs related to autoimmune disorders or viral disorders with the help of pharmacogenomics?
Sir, in case of autoimmune disorders, rheumatoid arthritis, polymorphism in the gene methyl tetrahydroxyfolate reductase can increases methotrexate serum level, and it is lead to toxicity in such patient with the rheumatoid arthritis.
But we are treating rheumatoid arthritis with methotrexate, no?
I don't know, sir.
Thank you, doctor.
Thank you, sir.
Thank you. Judges, please note that the next presentation is UG poster number 19. UG poster number 19.
Ma'am, can you hear me? Ma'am, am I audible?
Yes, you are audible.
Yeah, you're audible.
Ma'am, today I'm going to present on the topic oral health in pregnancy. As we have mentioned here, pregnancy, it is a unique period in a woman's lifetime. Good oral health during pregnancy is important to the overall habit of both expectant mother and her baby. Oral health should be a part of the comprehensive prenatal care for the woman, and medical practitioner obstetrician should consider of a new pregnant woman to a dentist as a routine. In the female sex hormone causes an increase in the oral vascular permeability towards bacteria, which decreases the host immunity. So certain features are represented during pregnancy due to this bacterial infections. First one, we here have pregnancy gingivitis. Pregnancy gingivitis is an inflammation of the gingiva, which is commonly seen during the pregnancy because of the plaque accumulation. This condition is receded after delivery, and good oral hygiene can prevent this condition. Next, we have pyogenic granuloma. It is also known as pregnancy tumor. So, an increase in the angiogenesis and coupled with gingival irritation causes this. The lesion presents as an erythematous lesion, which is painless swelling, and it is commonly seen in the labial aspect of the interdental papilla. Then this lesion is benign, so no other risk factors are seen during this time. It's mostly seen in the first trimester. Oral prophylaxis can be a good suggestive treatment for this condition. Next, we have erosion, tooth erosion that is mainly caused by vomiting, which is increased symptom during the pregnancy. Excessive vomiting causes the erosion of the enamel surfaces, and to prevent erosion, pregnant women can be advised of fluoride mouth rinses and brush immediately, and to avoid brushing immediately after the vomiting. So drugs like antiemetics and antacids can be used. Then we have pregnancy epilepsy. Pregnancy epilepsy is mainly a hyperplastic lesion that originates from the buccal mucosa and gingival tissues. This is also a formation due to bacterial plaque accumulation, and it's mainly seen in the second trimester. Gingival enlargement is also seen along with this. Main treatment is dental hygiene instructions, and we have certain drugs that are contraindicated during pregnancy. First one is tetracycline. Then we have vancomycin, metronidazole, sulfonamide, barbiturates, and benzodiazepines. So as we all know that prevention is better than cure, we can adopt full oral examinations before gestations. Effective dental care should be obtained using toothbrush, dental floss, etc. And gargling using mouthwashes and mouth rinses can be performed. A routine checkup can subdue everything and can help the patient to deliver a good baby and healthy baby. Thank you, ma'am.
If you're planning an intervention, at what trimester would you suggest to do that if it's a minor surgical intervention?
Sir, during second trimester, root planing can be suggested.
Are you aware of any drugs that is banned from India?
Yes, sir.
Are you
Sorry.
aware of any drugs that was banned in India because of this reason?
Sorry, sir, I didn't understand your question.
Are you aware of any drugs that has been banned because of this reason?
So tetracycline is not used due to discoloration of the teeth and hepatotoxicity to mother. So
Tetracycline is banned. That's still available, right?
yes, but mostly used is doxycycline instead of tetracycline.
Any analgesic? Have you heard about nimesulide?
So thalidomide.
Thalidomide. There's a committee for that.
Sorry, sir, I don't know.
Okay, doctor. Thank you.
Thank you, sir.
Which tooth is affected if the patient is having vomiting?
So
And why?
Ma'am, posteriors are mostly affected because of the presence of the duct and duct which causes excess salivation and calculus formation and plaque formation.
Didn't hear my question, right? Because of vomiting, which teeth are mostly affected?
Posterior tooth are mostly affected.
Why?
Ma'am, vomiting posterior tooth. Ma'am, posterior tooth is, ma'am, can you hear me?
Yeah, I'm listening.
Posterior tooth.
No. If the pregnant patient consumes alcohol, what will happen? Smoking causes teeth discoloration and so many other things. But in pregnant patient, what is it?
Miscarriage, ma'am. Miscarriage can occur, ma'am. Hello, ma'am. Miscarriage can occur. Premature. Hello, ma'am.
I'm listening.
Ma'am, hello, ma'am.
Yeah, I'm listening. Tell.
Premature birth, ma'am. Weight of the baby will be decreased. And there is an increased risk of miscarriage.
And alcohol? There's some syndrome associated with it, no? When the mother consumes alcohol. It's okay, no problem.
Thank you.
Thank you, poster number 19. Judges, please note that the next presentation is UG poster number 20. UG poster number 20. Moving on to the next presentation, judges, please note UG poster number 21. UG poster number 21.
Good evening, ma'am. Are you able to hear me?
Yes.
Good evening, everyone. Today, I will be presenting a poster on the topic vitamin D and oral health. So, the vitamin D is a fat-soluble vitamin. It is one of the most important vitamins that helps your body in absorption of calcium and the phosphorus. So, it is also been linked to the better dental health throughout your life. And it also has an important properties of antibacterial action and anti-inflammatory action. Moreover, the vitamin D is also necessary for mineralization of tissues in oral cavity And the vitamin D level affects the calcification of enamel of permanent teeth, rate of tooth eruption, and the position of the teeth. Whenever there is vitamin D deficiency, it can result in evident oral manifestations. Starting with the teeth, we can see the developmental abnormalities of dentine and enamel with increased risk of caries and hypoplasia of enamel. There will be motility, mottled enamel or yellowish gray in color of enamel can be seen. And the high pulp horns can be seen, and large chamber or even the delayed closure of root apices can also be seen. Coming to the relationship between the vitamin D and the periodontal disease, the vitamin D is the one that helps by reducing the inflammation and the associated bacteria. It encourages the immune system to produce the antibacterial peptides and inhibits the compounds like matrix metalloproteinases that damages the tissues. At the same time, the dietary calcium regulates the bone mineral density and can lower the risk of tooth loss. A low dietary intake of calcium can result in more severe form of the periodontal disease. The picture over here depicts the three form or the three conditions of the vitamin D. And the first one is that the vitamin D has two important functions, being autophagic in activity and anti-inflammatory effect. The autophagic activity prevents the formation of the dysbiotic film, simply called as the biofilm. And the anti-inflammatory effect can result in the inhibition of expression of inflammatory mediators, where both of them will prevent the formation of the gingival inflammation and its a further progression. At the same time, if we have a vitamin D deficiency, it can result in the bacterial invasion, further the gingival inflammation and the clinical attachment loss, and further invasion of the bone, resulting in the bone resorption and further the severe periodontitis. If at all, we try to conduct a periodontal regenerative surgery in a patient who has a non-vitamin D deficiency, one can say that the surgery would be one can say that the surgery would be a failure, because the metabolism over there, that is a bone formation and so on, so metabolism associated with it would be hampered because of the vitamin D deficiency. Coming to the relationship between the vitamin D and the caries. The vitamin D binds to the immune cells and your teeth to increase the amount of good antimicrobial proteins and reduce the bacteria that causes the dental caries. At the same time, mothers with the low vitamin D levels are more likely to give birth to children who develop dental caries. Here is yet another picture that shows the difference between the cross-section of healthy tooth and the vitamin D deficiency affected tooth. So whenever there's a vitamin D deficiency, we can see there's a calcification decrease, resulting in the hypoplasia and defects in the enamel prism, which results in the alterations in the shape, thickness, and the composition of dentine. Finally, there will be the decrease in the antibacterial activity, and so the loss of attachment, resulting in the inflammation increase and the bleeding on the probing, and further invading the bone, resulting in the osteoclastic activity and bone resorption. Finally, decrease in the mineralization of the bone. Yet another systemic condition that can be associated with vitamin D or the reduced vitamin D condition can be the osteoporosis. Actually, the osteoporosis is most commonly be seen in the women who in the postmenopausal women. So in that condition, the women will have an estrogen deficiency such that it can result in the cardiovascular events with a decrease in the ENO, increase in the renin-angiotensin-aldosterone system, which results in the hypertensive conditions, and also the inflammation with the interleukins, both of them contributing to the increase in the osteoclastic activity and hence the bone loss. At the same time, if we provide vitamin D, it can be we can maintain the level of the bone and can prevent the bone loss. Thank you.
Just to clarify, this was question number 21, Mama.
Yes, sir.
20 is missing, right?
Yes, sir. 20 is missing.
Okay. So how do you substitute if in case you find that vitamin D is deficient? How do you substitute?
We can use the vitamin D supplements or the vitamin D rich diet can be prescribed?
Vitamin D rich diet.
Yes, sir.
Which diet is that?
We can go for milk or egg. We can ask to eat cereals, beef liver or mushrooms, or either yet another thing is we can ask the patient to have the sunlight therapy.
There is a very common confusion regarding sunlight therapy. So some people say that you need to get sunlight early morning, early evenings, okay? And there
Yes,
are
sir.
schools of thoughts which says mid-afternoon you need to get sunlight to get vitamin D. So what do you stand?
Sorry, sir, I couldn't hear you.
At what time should you get sunlight to get vitamin D?
I think it's an early morning. Yes, sir, it's early morning.
Early morning?
Early morning.
Thank you, doctor.
You are living near the equator, right?
Yes, ma'am.
We get lot of sunlight.
Yes.
But currently people are talking so much about vitamin D deficiency. Why?
Sorry, ma'am, I couldn't hear you the last portion.
Even when we are staying very near to the equator where we get lot of sunlight, people are talking about vitamin D deficiency. One of the main sources of vitamin D is from the sunlight, from the skin, it is getting converted. But nowadays, everybody is talking about vitamin D deficiency. Any reason?
Ma'am, I think most of the people try to stay inside their home or try to work inside an apartment or building. My personal opinion is that those people are not. They prefer to stay indoors rather than going outside.
Okay, even if when you go out, what do you do?
I don't know.
As a beauty conscious girl, definitely you should know.
I think they use umbrellas or
that's okay, umbrellas. Anything else?
Sunscreen.
Yes, exactly. People are using so much of sunscreen. They are not allowing even one ray of sun to enter the skin, right? Preventing it. That is the reason why. What are the oral or manifestation? Oral in the sense all the oral tissues are included, including bone. Oral manifestation.
Including mucosal, right now, ma'am? Mucosal manifestation, specifically.
Everything, including all the tissues. Hard, soft, everything.
It can be developmental abnormality, more yellowish grayish color of tooth can be seen, or hypoplasia. Decrease in bond level can also be seen.
No, how will it affect the children? How will it affect the adults? I'll modify my question.
In children, it can result in a ricket condition, whereas in the adults, it can result in the osteomalacia.
What is renal osteodystrophy?
Renal osteo. It's a calcification of.
Why do we need vitamin D? First of all, tell me that. In the calcium metabolism cycle, where does vitamin D stand?
Sorry, ma'am, I cannot remember the thing.
Pardon?
Sorry, ma'am, I cannot remember.
Okay, no problem. Vitamin D is needed for the intestinal absorption of calcium. So
Yes,
even if
ma'am,
you
yes.
drink milk, even if you drink all the vitamin D rich food, it's not going to work.
Yes,
Unless
ma'am.
you have vitamin D. Right?
Yes, ma'am.
Yeah, so that's the reason. Okay. Okay.
Thank you, ma'am.
Thank you. Handing over to Dr. Lisa Elizabeth Jacob to wind up the UG poster session. Just making sure if poster number 7 and 20, are you here in the hall? Over to you, Dr. Lisa.
Thank you, Dr. Manjari. Thus, we have come to the end of the UG poster session. I would like to express.
Sorry, 1 minute. I just want to have a clarification. 10 is missing or 9 is missing?
1 minute.
5, 9, 5, 7, 9, and 20. Right now?
4, 5, 7, 9.
1 minute.
9 and 20.
And 20.
So 4 is missing, 5 is missing, 7 and 9 are missing, 20.
10 is present, no? Yeah. Okay.
Yes, ma'am. May I proceed now? May I proceed now?
Yeah.
Thus, we have come to the end of the UG poster session. I would like to express our gratitude to our judges for sparing their valuable time and being here with us today. As a token of our appreciation, I would like to present the certificates to the judges. Thank you very much, ma'am.
Thank you.
And Dr. Alvin, thank you so much, sir. Thank you to all the participants and delegates. The results will be announced later. Thanks again and have a wonderful day. Thank you.